He's not joined.
Yes, I'll call him.
Abhishek, can we start now?
Yes, ma'am. We will be live in 1 minute.
He's not joined.
So we are live now.
Excellent. Everybody right now?
Monica ma'am, should we start?
Yes, we can start.
Yes. Good evening, respected doctors. I welcome you all on behalf of Public Awareness Committee Fogsi with this tune for episode 3 of Core Connect live webinar. Coordinators for today's webinar are Dr. Monica Vardhan, she is in charge PSC activities, and Dr. Shatabdi De, she is convener PSC Fogsi. Dr. Monica Vardhan is MD, DPO, FCPS, DFP, FICOG, and LLB. She is consultant OBS and Gynae at Mangalia Nursing Home and Atharva Fertility Centers. She is PSC Committee Chairperson, AMOX 2022-24. She is website coordinator for AMOX from 2018 to 20. She is youth coordinator, AMOX.
There is
Yes,
a
ma'am.
lot of disturbance. Can you mute everybody?
Yes, ma'am. Just a minute, ma'am.
Don't read everything every time. Hello?
Yes, ma'am.
Yeah, don't read my introduction every time.
Sure.
It is okay. 2 lines are
Yes,
okay.
ma'am. Yes, ma'am.
Thank you so much
Ma'am,
for the kind
over to you for further proceeding, ma'am.
Thank you so much, Abhishek, for the kind introduction. I now would like to take honor in introducing our convener for the program, Dr. Shatabdi De. She is also the coordinator for the program. She is a consultant at Nova IVF Fertility, and she is also the convener of PSC Committee Fogsi. We welcome you,
Hello, all.
the PSC faculties, for this webinar. This is the third episode in the Public Awareness Committee webinar series. This also is started through medical termination of pregnancy contraception awareness among our fellow Foxians. We have done two successful programs, one with the West Zone on the 27th of January, and the second one was on the 9th of February with the South Zones. We have had an overwhelming response for both, and I acknowledge the participation of the East Zone societies and all the presidents and secretaries to make this program also a very grand success. Not wasting much of a time, let us seek blessings of Almighty to bless us for this webinar. Can we have the inauguration video, please?
वक्रतुंड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
Thank you, Abhishek. Actually, we cannot connect through Dr. Paisar. We will take his blessings as and when Sir joins. We have Mr. Vasu Sir with us. Sir, we first and foremost would like to congratulate you for the very successful conference. It was a great show put forward. We welcome you as the chief guest of honor for this webinar and seek blessings for the same. Can we have Sir's introductory slide, please, Abhishek?
I think that's okay, Monica. I think we are among friends, and I know everybody knows me here. It's great to be among friends, and I've joined from a flight mainly to say hello to the friends. And since
about nobody joining, nobody coming.
Since I will not be able to.
Please mute everybody.
Yes, ma'am. Yes, ma'am.
Sir
Yes,
is a
sir.
senior consultant and gynecologist.
Please.
Sir, you can please speak. Abhishek, unmute Bhaskar sir.
Yes, ma'am, I have actually unmute. I have asked to
Okay.
unmute. Yes, sir.
Okay. Okay. First and foremost, good evening to everyone. I could not resist joining from a flight just to say hello to everybody. And because I would miss Varanasi, where most of you will be there because of a family commitment. It's great to be among friends, to see Rekha Jha madam, Alka Pandey madam, Suman, the young Turks, Shatabdi, Niladri, Sharmishtha, Paushali, Dilip Da, Dr. Kiran Trivedi. It's great to see you all. I must congratulate the Public Awareness Committee for the wonderful work that they are doing. And Dr. Monica, you are outstanding with your commitment, contacting everybody, looking into the finer details. MTP and contraception never goes out of fashion. And I think I would take this opportunity to say, looking at what is happening in the United States with the MTP laws at the present moment, we feel proud Indians that we have one of the most liberal MTP laws, especially with the amendments that have come in now. So, but in what is important is that MTP access should reach everybody. Even now, we have the problem of unsafe abortion and its complications, and we may need to have access to contraceptive services nationwide. We are a diverse country with diverse geography and diverse economics, so one size does not fit all. We have an excellent program of one talk and two panel discussion with eminent panelists, moderators, and experts. And I'm sure that we'll have a very fruitful evening. Thank you again.
Thank you so much for the kind words, sir. Thank you for the appreciation for the community work. We assure you that we will be doing this all throughout the year. We will be having our webinars lined up every 15 days with all the zones. The next topic would be cervical cancer prevention and vaccination. So we would also ask active participation of all the societies of the East Zone for the anemia drive too, sir. If you could put forward the word across in the East Zones to participate, it would be much easier for us also, sir. Thank you so much for joining in and for taking time, sir. We will now move forward for the academic session. The first is the panel discussion on MTP and high-risk pregnancies, and I would invite our Vice President, Dr. Alka Pandey, madam. She is also the moderator for this panel. That is why, ma'am, I'm introducing you later. Abhishek, can we have slide, please? Ma'am is an associate professor of obstetrics and gynecology of Patna Medical College, also the vice president-elect Fogsi and the vice president in charge of TAC committee. She is also the member of governing council ICOG and the chairperson of Practical OBGY of Fogsi on 2015 to 17. She has been a national corresponding editor of Jogi from 17 to 23, ma'am. We welcome you, ma'am. Our next moderator for the session is Dr. Rekha Jha, madam. She is the convener of this series also. She is the current president of Bhagalpur Obstetric and Gynecological Society. She is also the East Zone coordinator for PAC Committee Fogsi. She has been the organizing chairperson of the 9th All Annual Conference of the Bengal Societies. She has been the scientific chair of IMA Bhagalpur and the past president of, secretary of IMA, past vice president of IMA Bhagalpur. We welcome you, ma'am.
Thank you.
I would now introduce our expert panelist, Dr. Dilip Kumar Datta, sir. He is the chairman of IMA Maternal Mortality Cell, IMA headquarters, New Delhi. He is also the editor of Journal of Indian Medical Association 2017. He is also the Dean of Indian Academy of Obstetrics and Gynecology in 2016 to 18. He has written over 40 books and has many Fogsi publications to his credit. We welcome you, sir. Before I introduce all the topics, I would like Alka madam to please give your remarks and blessings to this webinar also, ma'am, so that we can then move forward to the panelists. Alka ma'am. Rekha ma'am, madam.
Madam Alka Pandey, मैडम आपको ब्लेसिंग्स देने के लिए बोला जा रहा है. Kindly bless us.
Hello.
Yes, madam.
Oh, good evening, everyone. Good evening, Dr. Bhaskar, Dr. Basav, Suman, Kiran, Rekha, Satabdi, and everyone present over here. I only have to say that you are doing fantastic job. This Public Awareness Committee, Monica is very hardworking and she's coordinating all the meetings very well. And Satabdi also, Priyankur also. So let us begin.
So, with the permission of our expert, Dr. D.K. Datta, who has joined today.
Hello.
So, yes, sir, would you like to speak something?
No, thank you very much. Because I am on the way to Durgapur in the
So
car.
so should we start now?
Yes.
So, Monica, would you like to take the names of the panelists and a short introduction of the panelists? Yes.
Yes,
So,
sir. I will introduce all of them and then we start with the panel.
Monica, I think your internet connectivity is not very good.
Yes, ma'am. The first panelist is Dr. Bidisha Roy Chaudhary. She is a fellow of minimal access surgery, a consultant obstetrician and gynecologist and infertility specialist, a RMO from clinical tutor in IPJME and RSKTM Hospital, Kolkata. She has published over 10 papers in national and international journals. The next slide, please. Our next panelist is Dr. Kiran Trivedi, madam. She is a gold medalist in MD OBGYN. Her designation is Assistant Professor, Department of OBGYN, RIMS Ranchi College. Organizing Secretary of Fogsi E-Zone Conference UR 2022. She is the Secretary of Ranchi Obstetric and Gynecological Society from the year 21 to 23 and currently at present the same post. She has been an ex-joint Secretary of Ranchi OBGYN, ex-treasurer of the same society. She is also a life member of IME, Fogsi, INSUPAB and IFS. We welcome you, ma'am. The next slide, please. Dr. Roma Yadav, ma'am. She is currently the Vice President of Bhagalpur OBGYN Society. She is a member of MTP Committee Fogsi, also the Chairperson of MTP Committee Bhagalpur OBGYN Society, the past Secretary of Bhagalpur OBGYN Society. She has been the Chairman of IME CGP, Senior Member of Doctor Protection Committee IMA, and the Life Member of IME. She is the Organizing Secretary of the 9th Annual Conference in the year 22. We welcome you, ma'am. The next slide is our next panelist is Dr. Kavita Barnavan. She is the Senior Consultant and Laparoscopy Surgery at Samarpan Hospital. She is a recipient of Padma Bhushan Kamlabai Hospital Award. She is a member of ITP Committee Fogsi for the year 21-23. She is also the Organizing Secretary of the Annual Conference, Life Member of IIG, IMA, Red Cross, IMS and SOCI. She has been trained in IVF under ICEAT. She has been invited as a patentee in national and state, international conferences, and she's contributed many chapters in JP books. We welcome you. Our next panelist is Dr. Sharmishta Kampali. She is the RMO tutor at NRS Medical College. Her special interests include high-risk pregnancy, vaginal surgeries, and gynecology. Dr. Sani is a fellow of minimal access surgery. She is a fellow in gynecological laparoscopy and reproductive medicine trained in Kiel, Germany. She is also the fellow of International College of Robotic Surgeons. She is a consultant obstetrician, gynecologist, laparoscopy surgeon, infertility specialist practicing at Woodlands Hospital, Bellevue Clinic, and Dhakuria RSP Hospital. She is a part of managing committee member of BOGS and a member of Medical Disorders and Pregnancy Committee Fogsi 21-22. Our next panelist, Dr. Siddharth Majumdar. He is an assistant professor at ESIC Medical College Hospital, Kolkata. We welcome all of you. I am sure the ACE panel moderators will bring out the best in the galaxy of stars that we have today. Over to you, Rekha ma'am and Alka ma'am.
Okay. Should I start sharing the slides?
Sure.
Madam?
Yes, yes. Rekha, shuru karo.
Yes. Somehow I have to stop my video because it comes on the screen. So is it okay with everybody?
Yeah, it's okay.
Yes, ma'am. Yes.
So,
Yeah.
So we started. As you all know, the panel is on MTP in high risk scenario, safe practices. The panelists and the expert and moderators have already been introduced. So I would just like to speak. Access to safe abortion protects the women's and girls' reproductive health rights. Abortions are safe when they are carried out by following the rules and regulations framed under the MTP Act of 1971. Now, there are some features of MTP Act 2021. Abortion period has been extended from 20 to 24 weeks. Opinion of one RMP required up to 20 weeks of pregnancy. Opinion of two RMP is required for 20 to 24 weeks of pregnancy. Access to safe abortion for unmarried girls has been provided, and protecting the privacy and confidentiality has been made a law. So the essential protocols of safe and legal abortion is that it should be performed by a registered medical practitioner as defined under the MTP Act. It is performed at an approved site. It should be performed at an approved site under the Act and recorded in Form 3111. Other requirements of the Act, such as consent form C, opinion form 1, monthly reporting form 2, etc., are fulfilled. The pregnancy is within the gestation limit approved by the law. The provider will get the protective cover of this legislation only when he or she fulfills the above mentioned requirements completely. So the most important thing is that who is performing, where it is being performed, whether the form 1 or the opinion form has been filled or not by the RMP, whether the monthly reporting has been done or not, and whether the consent form is there or not, and also how it is entered in the register, that is in the 3. So MTP is a nightmare in some medical disorders, and they are being refused at early pregnancy when it is safer than performing in late or advanced pregnancy, or if they continue the pregnancy. So providing them safe, supervised abortion services is considered, should be considered over just refusing safe abortion services merely because of high risk factors. This means that even though high risk factors are there, early abortion should be done and it should not be refused. Now, going over to the questions. Dr. Bidisha, are you ready?
Yes, now let's.
Yeah, Madam.
Dr. Bidisha,
Yes,
these
ma'am.
are the high risk groups for MTP.
Yeah, the high risk groups are, as already ma'am said, that with complicated medical problems, also women who are teenagers less than 19 or very elderly like post 40, along with complicated heart disease or uncontrolled hypertension and diabetes, along with that when they have chronic kidney disease or any complicated rheumatic heart disease with other complications, and any when they're having HIV or AIDS or the hepatitis B positive or hepatitis C positive in those cases. Also in cases of malignancy, like cervical CA, they fall in the highest group. And with multiple surgeries on the uterus, like previous cesarean section or any other previous hysterectomy or other surgeries, they also fall in the high risk group.
Also in cases of congenital uterine malformations, because sometimes there is a rudimentary horn and septate uterus, they are also quite high risk.
Yes.
Now, anything anybody would like to add? among the high risk group. I think it has been extensively prepared. The next question, how would you take the consent before doing this MTP? Dr. Kiran, I think you are a member of that PCNDT body in your place. Where are you, Dr. Kiran?
Hello. Good
You
evening.
are, yes. How would
So,
you take the consent before doing MTP?
whenever a patient comes to us, first of all, we have to take proper history to ascertain about the age, because we have to get the satisfactory answer in which age group she is belonging. If she is belonging to minor group, we have to take consent of guardian. And if she is major, we can take consent of patient itself. Second thing, we have to ascertain the gestational as well, because if she is with pregnancy less than 20 weeks, single RMP can give opinion. And if it is more than 20, then opinion of two registered medical practitioner is needed. So these two things should be kept in mind. And then we have to take consent, that is Form C, and it should be duly filled. Second is Form 1, and it should also be opinion of one RMP if it is less than 20 weeks. And if it is more than 20 weeks, then opinion of two RMP is needed. Next is Form E and D. If gestational age is more than 20, then we have to take consent in Form E, and D is the opinion of board. If it is more than 24 and non-compatible to life, or it may be due to severe health hazard to women. So these are the forms. After proper detailed examination and filling the form, then we should proceed for MTP, and these forms should be, and Form 2 should also be filled properly, because we have to send the reports. Every month we have to send the report to CMO. And third thing, Form 3, which should be procured, properly filled admission. So these are the forms which should be filled, either it is surgical abortion or medical abortion.
So Dr. Kiran, you have told about all the forms, but you missed out on form, the admission register. That in the admission register, when you write down all the details, you have to take one thing, that you have to put the Form C and the opinion form, and the Form 1 or E or whatever it is in an envelope, sealed envelope, and then just put the serial number of in the admission register. There is a column of serial number, and one of the serial numbers should be on that sealed envelope, so that it should be confidentially kept and it can be disclosed only to the CMO. So this is very important about the documentation, because if proper documentation is done, then only law is going to protect the registered medical practitioner. Also, one thing that when you are talking about registered medical practitioner, who are the RMPs who are entitled to do this MTP? 71, it was something different. A bit of modifications have been done. Yeah.
So all the students,
everybody having a MD or DGO in Obs Gynae, whoever has worked for a period of
house surgeonship.
Yes, 1 year in Obs and Gynae, but or anybody who had assisted 25 cases. This was the previous one, previously in 71, but now they have changed a little bit. And even if in a hospital where MTP is being done and somebody has worked for 3 months, they are also considered eligible to do MTP, and even if they have assisted in 10 cases. Previously it was 25, now it is 10 cases. And if they have done independently in 5, then they can do this MTP, because many things come under the medical termination of pregnancy. So because of MMA, these modifications have been done. So anybody else wants to add something? about the documentation or about RMP, about the place of where it can be done. It should
be registered.
The
place
registered. What?
And no,
the place should be
registered.
So the application in Form B has to be given, in Form A has to be given, and the approval by the CMO is in Form B. That should be in the place where it is being done. It should be displayed also, it should be present. Otherwise, you are not protected if you are doing MTP. So, Alka madam, should we proceed?
Yes, yes.
Yes. So when pregnant women come for MTP, first you have Dr. Kiran has already told, confirm the pregnancy, the gestational age, identification of MTP indication, discuss the method of MTP, and also discuss contraception counseling. And then perform MTP, obtain informed consent. All the forms have to be filled. In case of medical abortion, all forms have to be filled. That is very important. All record to be preserved till 5 years of the last entry of the register. In admission register, serial number 1 will be always restarted from 1st January. So these are some important points that we should not miss, that every year it should start from from the 1st January and have to be, everything has to be preserved for at least 5 years. This is mandatory. So the word mandatory has been written in. Madam, over to you.
So how would you counsel this patient before MTP? What counseling you should do to the patient?
Good evening, ma'am. When a patient comes for MTP to us, first of all, the patient should be seated in a very comfortable room, in a comfortable position, and the patient should be relaxed. And we should use the such type of language so that the patient can understand easily and can give answers in a simple language. And there must be a good rapport between the treating gynecologist or the whoever is doing this, whoever the provider of this service and the patient. And during this procedure, one should explain everything regarding the procedure of the MTP, regarding their future fertility, and regarding also their contraception. We should explain everything, which method we are going to use for the MTP. And if we are using this medical method of abortion, before that, we have to know the age of the patient and also the gestational age. And if you are using the medical method of abortion, then we should explain in a very simple language where the misoprostol should be used, whether at in a clinic or at the home. And in case of any emergency, where she has to report. So the contact person, the contact telephone number of the clinic or the contact person should be given to the patient so that she should not be scared of any type of complications. We should also explain about the complications like the severe hemorrhage or pain abdomen and everything, and explaining all the things. Again, we have to explain that you may conceive. So you must, if you are preferring this abortion, then you must use contraception. But one thing is here, clear-cut thing is that if the patient is not willing for contraception, it doesn't mean we will not offer the MTP. We will offer the MTP. We will counsel again and again for the contraception, and we should be very friendly, and the confidentiality of the patient should be maintained. So that Dr. Rekha madam has already told, all the forms should be kept, Form C and Form 1 in one envelope and sealed envelope, and should not be disclosed to anyone.
Okay, very good. So MTP should not be denied irrespective of the woman's decision to refuse concurrent contraception. Because if you deny it, she will go to a quack and she will land into unsafe abortion.
Yeah.
Okay, next question.
Now the next question to Dr. Kavita. Is there any room of ultrasound?
Madam, routinely, we don't require ultrasonography just for doing MTP. We have to take proper history. We have to do examination we can go pelvic examination, especially in married women. In unmarried women, ultrasound is necessary, but sometimes ultrasound is necessary to document the pregnancy, for dating of the pregnancy, because sometimes patient may get confused. So just to rule out what is the exactly date of the pregnancy, and sometimes to rule out ectopic pregnancy or any other abnormality of the uterus, congenital anomalies, fibroid or any other tumor. So in these conditions, or in scarred pregnancy, because if the patient has got previous surgery of the uterus, so there are chances to scar pregnancy. So at least we have to go for it to rule out the scar pregnancy, and also whether she has got any other types of complication. So just before MTP, ultrasound is done in these conditions, but it's not mandatory or binding. And after MTP, there are chances of failed medical MTP. Many women get a medical MTP and they have got incomplete abortion. In that case, we have to go for ultrasonography. And sometimes even surgical process has been done, but still there are chances of incomplete evacuation. Then we have to go for ultrasonography. And in also when there are any complication like chances of perforation after surgical evacuation or any other abnormality, then we have to go for ultrasonography to rule out heterotopic or ectopic pregnancy, and sometimes to rule out gestational trophoblastic disease also, because the treatment will be different. So these are the conditions where ultrasound should be done, but nowadays ultrasound is so freely available. So I think before going for MTP, we can advise ultrasonography because it's easily available at all the sectors, even government as well as private sectors.
So it is like what you said, you explained very well that it is not necessary, it is not mandatory, but any clinical suspicion if you have that maybe it is trophoblastic disease, or maybe there is a twin pregnancy, maybe it is unduly enlarged uterus or something, or there is anything like that, then you can go for an ultrasound where it is available and if it is easy. And after the surgical MTP, of course, if there is any suspicion of any type of complication, you have to go for ultrasound. So and you said very well that in most of the clinics we have ultrasound. So if possible, it depends upon the provider. If he wants to do, he can do it, but it is not mandatory. Because many rural places, they don't have ultrasound, and abortion should not be denied there. So thank you so much.
Now, if a woman comes to you, Dr. Sarmishta, for MTP, 10 weeks size about, what method of MTP would you adopt?
Madam, preferably we now go for medication abortion, which usually contains a single dose of mifepristone followed by misoprostol in most of the cases. And it is obviously after I counsel the patient properly and tell regarding the complications. It can be also given on OPD basis, and I can explain the patients regarding the complications, and can be given on home medicine also. Hello?
Yes. So, Dr. Sharmishta, you have said that because of the availability of mifepristone and misoprostol, and even it has been, the efficacy has been proven worldwide. So you can give it, and it should not be that close medical supervision is required. So and the patient can be discharged, can go home and report back if there is any problem. That is what you say. Okay, thank you. So the next question is to Dr. Siddhartha.
Yes, madam. Yes, madam, I'm there.
What medical abortion protocol would you like to follow?
Yes. So coming to that, there are different drugs which are now being used very widely. And in that, as Dr. Sharmishta madam correctly said, we are giving mifepristone and misoprostol combination regimens. So there have been various regimens, but the latest one we are following is the regimen in 2017 by Fogsi. And so I will be following that depending upon the weeks of gestation. I will first ask the patient or either from the ultrasound or from the date, I'll get to know the weeks of amenorrhea. Following that, I will then go back to the chart and I will see as to what regimen I shall follow. Depending upon that, I will advise the patient on the dose of mifepristone and misoprostol accordingly, and I will also tell her the risks involved and the side effects which she can get with these drugs.
Okay. Madam, would you like to add something, madam?
There is in FIGO and in 2011 and 2017, less than 13 weeks, they have repeated 800 microgram of misoprostol every 3 hours, 3 to 12 hourly in 2 to 3 doses. And more than 13 to 24 weeks, 400 microgram every 3 hours. Suppose the patient does not go into labor after this also, what has to be done?
Ma'am, we can also use certain mechanical methods which were used earlier, like balloon catheterization. And basically, if the cervix is ripened, that is our main reason. If the cervix is ripened, then we can also go for balloon. Hello?
Police catheter you can use for ripening the
Police
cervix. Yes.
And then once the cervix is dilated, we can also use
And
dinoprostone
inducing
gel.
abortion. Yes.
Yes, ma'am. Dinoprostone gel can also be used.
But ma'am, before that, we should confirm whether the abortion has taken place or not. If there is retained products of conception, we can use misoprostol again. 400 microgram to 800 microgram misoprostol can be repeated. And if there is viable pregnancy, then we will go for another method for cervical dilatation and then evacuation. It will evacuate, either it will evacuate spontaneously so that the removal of POC can be done by finger or any. And
many times the pain does not start.
Yeah, then
Madam is asking that if there is no pain at all, if there is a resistance to the
then there is a place for cervical dilatation.
So that is what Siddhartha was saying.
Yeah.
And that you can do if you have used the maximum amount of dosage that is according to FIGO guidelines. So the drug protocol in the first day, 200 milligram mifepristone. Second visit is third day, 400 misoprostol. This is the drug protocol of Government of India. So everybody should know that FIGO has another protocol, and Government of India has given the rule of first, second, and third visits on the day 1, day 3, and day 15. And for the first day, 200 milligram mifepristone, and 400 on the third day, 400 milligram misoprostol, and on the 15th day, confirm and ensure the completion of abortion, and then offer contraception. And these are the WHO guidelines of 2018, again similar on the lines of the FIGO guidelines. So should we pass on to the next question?
No, one thing more.
Yes, madam.
This ultrasound on 15th day, I think, is very important, because one of my patient came and said, Madam, I have had a good amount of bleeding and everything has been passed off and this and that. And after 3 months, she again came back.
She's continuing with the
pregnancy. When I examined her, she was continuing pregnancy 4 months. So this, I think, on 15th day, you must confirm by ultrasound that whether the abortion has been completed or not.
So yes, it is confirmation, and that should be done. And ultrasound is, of course, the best way to confirm. So going on to the next question. Is Dr. Mariam here? Madam,
how would you follow the case, Dr. Mariam?
Are you there, Dr. Mariam?
Yes, ma'am.
Yes. Then speak out.
Ma'am, in medical method, there is 3 visits on first day, third day, and on 15th day. In first day, we will take the proper history, proper examination. We will counsel the patient regarding the method, regarding when to report, what is going to happen. We will counsel her regarding the contraceptive method that she can adopt. And on first day, if she is Rh negative, we can give her anti-D, and inform consent should be taken. And on the tablet mifepristone is given on the day 1, and on second visit, that is on the third day, tablet misoprostol we can give according to the gestational age. And in clinic, we should observe the patient for 4 to 6 hours. It is the usual time in which the product expelled, and a proper analgesic should be given to the patient for control of the pain. After, allow her to go to home. After discharging the patient, a proper bimanual examination is important to confirm whether the product of conception is expelled or not. And we must warn the patient regarding the warning signs, when she will report if there is excessive bleeding, if there is foul smelling discharge. And card is given to her, and we can tell her to keep the recordings regarding the symptoms, regarding the bleeding. And after the usual time is 8 to 13 days, the bleeding can persist. We should counsel about her. And on 15th day, that is ma'am also now told that it is very important to confirm the total method has completed or not, proper bimanual examination. And if there is any doubt, USG is mandatory to confirm whether the total product is expelled or not. We should explain the patient, if there is no period for the next 6 weeks, she should come again to report.
And also about contraception, you have to counsel her about contraception.
Yes, ma'am.
Yeah.
Now the contraindications for medical abortion. Dr. Paushali.
Yes, ma'am. So there are different contraindications. Number one is if there is any allergy to any of the components or the drugs which are being given for medical abortion, like misoprostol or mifepristone. Then other systemic disorders, for example, severe anemia, if her hemoglobin is less than 7 gram per deciliter, or if she's having uncontrolled hypertension, her blood pressure is more than 160/100, then we do not give a medical method of abortion, because the blood pressure is going to increase with misoprostol. Also, if she has any uncontrolled renal or respiratory diseases, or if she has any other cardiac diseases like ischemic heart diseases, uncontrolled angina, or any other any valvular heart disease or arrhythmia, then the misoprostol and mifepristone, the medical method, is contraindicated. If she's on other medications, for example, if she's she's currently undergoing long-term systemic corticosteroid therapy, or she's currently on any anticoagulants, then this method is contraindicated. Among the other disorders, if she's having neurological problems like uncontrolled epilepsies or uncontrolled seizures, or if she has any glaucoma or inherited porphyrias, then medical method is contraindicated. Another very important contraindication which is often encountered is if she has any suspected or confirmed ectopic pregnancy, or if she has any undiagnosed adnexal mass, then we do not give this medical method of abortion.
So you have spoken on everything, that if she is having any anemia, severe, less than 8 grams, so it might become like medical. If you give the medical pills and send her home, then she might bleed a lot and it becomes dangerous. So you have to see all these things that are on the screen. An ectopic pregnancy, undiagnosed adnexal mass, uncontrolled hypertension, heart problems, arrhythmia, severe renal, liver, or respiratory disease, current long-term systemic corticosteroid therapy. current anticoagulant therapy, inherited porphyrias, uncontrolled seizure disorders, allergy or intolerance to these drugs, and glaucoma. So in the back of your mind, there should be that whether she is on anticoagulants or not, whether she is suffering from any disease or not. So a detailed medical history is always required whenever you are advising a simple thing as a medical abortion. So every time a patient is a challenge, so you should always have in mind she might have anything, any of these things. So should we proceed?
Yes, yes. So you should be alert. Pregnancy with intrauterine contraceptive device. So you have to remove the IUCD before giving drugs. Then pregnancy with uterine scar. You have to be cautious because it might rupture. In cases of bronchial asthma, misoprostol is a bronchodilator, but not other prostaglandins. Prostadine should not be given in cases of bronchial asthma. Then pregnancy with fibroid and women on anti-tubercular drugs. You have to be very, very cautious. Next slide, please. So if bleeding is excessive, how will you manage? Tamami?
Madam Tamami, I think she is not in this panel. So mistakenly her name is there. So I would like to ask Dr. Kavita if she is there. Dr. Kavita, are you there? Dr. Kavita. Dr. Kavita Barnawal, please unmute yourself, Dr. Kavita.
Yes, madam.
If bleeding is excessive, how to manage?
Yeah. So depending upon the condition, what is the size of the uterus and what is the time of the pregnancy, we have to manage. First, we will start IV land, and then we will get our CBC done. And immediately, if the hemoglobin is very low, then we will start blood. And by the time, misoprostol tablet, IV syntocinon, either in the drip or bolus, even methyl ergometrin, IM. And if still bleeding is continuing, then we will get prostaglandins also, like prostaglandin F2 alpha. And even after that bleeding is continued, then we will get our ultrasonography done, and we'll see whether there is any injury to cervical structure or any vesicovaginal plexus or even broad ligament hematoma. So we have to see, and accordingly, even after dilatation evacuation or ultrasonography guided products are removed, conception are removed, and still there is bleeding, then we will go for laparotomy so that we can see what is the exact condition and what is the cause of the bleeding. But mostly with conservative management and with evacuation of the products of conception, patient mostly gets bleeding is controlled, and we have to infuse her blood so that she gets rid of all these complications.
Kavita, in most of the places, gynecologists don't have ultrasound. So you just can't go and get ultrasound done, and the patient is bleeding. So then and there you have to control the bleeding.
Madam, then we will start IV land. We will give syntocinon IV. We will see the uterus condition of the uterus, and then if we find that any products is coming, then we will remove. Gentle curettage will be done, and we will give all the oxytoxins like prostaglandin, misoprostol, syntocinon, methyl ergometrin, so that she gets rid of.
That is what I wanted to say. If everything has failed, one thing we can do, that is you can do a tamponade. What I have tried in 2 or 3 of my cases, when the bleeding was not responding to anything,
I also wanted to add that.
Foley's catheter, 30 ml with normal saline, inflated, put into the uterine cavity, and that worked wonderfully well.
Okay, madam, we have found that suction evacuation, because it creates negative pressure, and many times bleeding is controlled with
no suction evacuation we are already doing after this. That is what I was telling you about when we are doing suction evacuation, not about medical abortion. What you are talking, even after this medical abortion, if it is incomplete, it will bleed. But even if you are doing suction, sometimes bleeding does not stop, and in that case we have tried this Foley's catheter and inflated it with 30 ml of saline, kept it for 24 hours, and then gradually that saline was taken out, and it worked well.
Okay.
Ma'am, we had
And
tried
generally it happens in case of
Tight
chronic
packing
abortion
also helps,
when
madam.
the
Tight
product
packing
of
of the
conception is more than 15 days, and then you are evacuating the uterus. The bleeding usually comes in a flow, and then we will use this Tempodad.
Agree.
Okay, let us proceed.
So
We have very little time left.
The main thing was that there are two scenarios, stable condition or unstable condition. So act accordingly. Other MTP options, Dr. Bidisha, are you there?
Yes, ma'am.
What are the other MTP?
Yeah, the other MTP option is one of the safest is vacuum aspiration if it's available, because different sizes cannulas are available. So if we do a PV and accordingly, according to the size of the uterus, we can use the perfect number of cannula, and they're already color coded. So it's one of the safest method. If that's not available, then we can go back to the old method of dilatation and evacuation followed by curettage if required. And hysterectomy is only preserved for those cases in post-CS pregnancies which are not responding to any other methods, and it is already near to 20 weeks or beyond 20 weeks. In few of those cases, we had to resort to hysterectomy, but it is the last
Especially
resort.
if placenta is low-lying.
Low-lying
And there are
placentas.
chances of bleeding.
Bleeding,
then
yes.
we have to we should do hysterectomy, but mostly other methods like dilatation, evacuation, and aspiration will help.
Yes.
So what you meant is that most of the cases vacuum aspiration, then next comes dilatation, evacuation, and then hysterectomy in those cases where as a last resort where it is not responding and there are chances of any more complications. So we go on to hysterectomy. So all aspects should be delivered in a respectful and sensitive manner, and of course, the due respect to the patient is to be given by the provider. Now, we are going to speak of some cases. So, anybody can answer. 23-year-old lady, gravida 2, para 1, with 3 months amenorrhea, contraception by condoms, abdominal pain for 3 days. She is anemic, uterus is 16 weeks, irregular and tender, PV is, os is closed, scan shows multiple fibroids, 12 weeks, size due to persistent pain. The couple wants to get an abortion done, get an MTP done. So it goes to Dr. Kiran. It is already fixed on her. Difficulty you might encounter while doing MTP in a uterus having fibroids. Madam Alka Pandey, I think. Madam,
yes, you go ahead. Kiran,
Okay.
answer this question. Difficulty which you might encounter while doing MTP in a gravid uterus with fibroids.
So this is documented that this is 13 weeks pregnancy, but size of uterus is large due to presence of multiple fibroid. That is one thing. So we have to see during this doing MTP, if we are proceeding for surgical abortion, there might be cavity might be distorted. So there might be difficulty negotiating. So there may be excessive bleeding. There may be excessive pain. There may be retained products may be left behind. So whenever we are encountered with such type of cases, either we are going through medical abortion or surgical abortion, there are always chances of exaggerated bleeding, pain, sepsis, incomplete abortion, and sometimes perforation of the uterus if we are negotiating on false passes. So these are the important possibilities which should be kept in mind while doing MTP in such cases. But in this case, this is 13 weeks pregnancy. So we will not proceed for surgical abortion. We will go for medical abortion.
But I think this is a case of previous cesarean. So there are
No,
chances of return.
No, this is not a case.
Oh,
this is
okay.
not
This is not a case.
Yeah, then all right. Then we will go for medical
fibroid.
abortion. Yeah. Then we can go for medical abortion. Yes.
And it's 13 weeks, so we have to go for medical abortion.
Yes.
And if anything left behind, then we can do evacuation
Later on,
if
we can
needed.
take out.
Yeah.
Rekha.
Yes, madam. Boliye.
I want you to take that case. Unmarried girl, 13 years, comes for abortion, because I don't want to miss that case, because these girls often come to our clinics.
बहुत पीछे है क्या?
थोड़ा सा पीछे, बस अब आ गया. We can take it. हाँ. इसके बाद. इसके बाद.
अच्छा. हाँ, ये है क्या? नहीं. 20 years old. ये वाला था.
ये और आगे है.
इसके बाद है.
हाँ.
यही.
So, a young girl, 13 years with amenorrhea, 3 months. On examination, 16 weeks pregnancy, confirmed by scan. What are the procedures to be followed, Dr. Roma?
Ma'am, since this girl is 13 years old and she is below 18 years, this case comes under the POCSO Act. That is Protection of the Child Against Sexual Offence Act. And this must be kept in the mind before starting anything. So we have to do the MTP. This is mandatory to do the MTP. But before that, the proper authorities should be informed regarding this case because she is 13 years old. We can inform the local police, or we can dial the number 1098. That is the child helpline. That there we can also inform. And after informing, we will not wait for further action to be taken by the police. We can go ahead. And everything should be done under the MTP Act. And in this, the girl is 13 years old, so the guardian signature is necessary over the consent form. And again, all the forms, all the documentations registered, everything should be filled in a proper way, in a lawful way, so that way nobody can land up in a legal situation. And we will not wait for the authorities to give the response, and we can go ahead for the MTP procedures. And her 16-week, it is, I think, the 16-week pregnancy, and it should be confirmed by the ultrasonography. There is also role for ultrasound in this very case, so that everything should be confirmed and documented. Ultrasound is again a tool for documentation also. And after that, we will go for medical method of abortion. But before that, the necessary investigation should be done like the ABO RH typing, because if she is RH negative, the NTD should be given. To this case, the hemoglobin estimation, because she is 13 years old, girl, hemoglobin must be checked. If she is anemic, blood should be erased for any further complications. And everything should be done in a very safe way to save the life of this 13-year-old girl.
Madam, do you want to say anything, madam?
No.
So it has been covered?
Yes.
So the main highlight was that in this case, since the girl is 13 and a minor, the signature of the guardian is required. Information to the authorities should be done, and in a safe manner, the medical abortion should be started, keeping in mind everything, how to act whenever any complications arise. So we should go back to the...
Rekha, madam, one thing I would like to add, the girl should be kept in the clinic, because if there occurs the excessive bleeding or pain, she will not handle that situation. So I think the misoprostol should be offered at the clinic. on day 3.
Okay.
In respect to same thing, madam, I wanted to ask something like, do we have any guidelines like whom to admit and whom to not for?
No, I'm just telling about this particular case.
Yeah.
She's a 13 years old girl. She can't handle every situation at home.
At least we should have told her that she should report immediately. If she goes home, then we have
Then
to
she should,
say
yeah.
that these are the danger signs and you have to report immediately. Whether she
Immediately.
lives away from that clinic, then she should go to first center where all the facilities of
Or otherwise we will counsel the parents. Otherwise we will counsel the parents or the guardians about the warning signs of this MTP procedure.
I'm trying to find out where we had left.
Yeah, here only. Just a few slides back.
Oh, few slides back.
Yes, this is the place.
Scarred uterus and MTP.
Scarred uterus. Back. Scarred uterus. थोड़ा सा पीछे.
High risk factors.
One slide back. Scarred uterus.
And this is the slide.
Yeah.
We were talking about this. No, this was the second case that we had to deal. We had finished this one, first case. So this is the second case in which 28-year-old lady comes with amenorrhea 13 weeks, G3, P2, both LSTs, delivered only recently 10 months back, had an IUCD inserted, removed due to bleeding, was using condoms. Now she wants MTP and she is B negative. So she has previous 2 CS, B negative, and she is bleeding and she wants MTP. So how would you proceed?
In this very case, since the patient has 2 previous cesarean sections and the last child is only 10 months old and the patient is RH negative, all the 3 things should be kept in mind, and a detailed history should be taken from the patient regarding their previous operations, previous 2 cesarean sections, and the duration of the intraoperative. Was there any complication during their previous cesarean section operations? That should be clear. And if something, some input are coming, it should be kept in mind. And again, the patient should be asked about the various medical disorders, if he is suffering from hypertension or diabetes or any renal or hepatic or diseases or any bleeding disorders, or if she has any drug allergy, because we have to give the medical method of abortion in this case. So before that, we should know everything about the patient. And since this can land up in severe bleeding or anything, before that, we have to go for ultrasound. Ultrasound is very much mandatory in this very case, so that we can rule out the scarred pregnancy or ectopic pregnancy that is very common in previous cesarean section. At the same time, there may be past, that is placenta accreta syndrome or abnormal placentation, and that these things should be ruled out before starting this medical method of abortion.
Yes. Ultrasound will tell you about the
scarred pregnancy,
the position of the placenta and the scar also. Thin scar, and counseling should always be done because it is a high risk thing. Which you have to do, and in this case more of pain will be there, so pain management should always be looked into, and you should be prepared,
and also the blood should be arranged, hemoglobin estimation,
antibiotics and everything.
Because only 10 months back the cesarean section has been done.
Yes, while discussing this, I remember one of the cases which had previous to cesarean, and the patient had adhesions of the gut to the uterus, bad adhesion of the gut to the uterus, which later on, when she was aborting, there was a big problem, too much of bleeding and even perforation with the gut coming out of the uterine scar. Then we had to repose it, and then laparotomy was done to.
That should be kept in mind. That's why the OT should be prepared. And in this case also, the patient should get admitted, because it is a high risk case of and patients should get admitted, so that we can counter, we can see any complications, and we can do accordingly.
And post-procedure ultrasound and follow-up is very, very, very important in this.
Important, and again, the role of contraception also.
So these are the enumerated high-risk factors for complications in such cases. If there are multiple incisions, and if there was a second trimester abortion, of course, the scar must have been longitudinal and duration of the last surgery, if it is very recent. Which method would you suggest, Dr. Paushali?
So, ma'am, basically, we can go, she's 13 weeks. So we can go for a medical method of abortion, but since she has 2 previous cesarean sections, the dose of misoprostol needs to be tailored. Now, according to guidelines, there is no contraindication to misoprostol in case of scarred uterus if we use it. But yes, we need to give her lower doses of misoprostol, and the frequency with which we administer, the frequency of repeating the doses of misoprostol, basically that needs to be increased, because what we always have to keep in mind is the risk of uterine rupture. And since she has delivered another baby 10 months back, so the scar also, it's not that strong. So basically, we need to tailor it according to the patient's response. So we give a dose of mifepristone first, which is 200 micrograms, but then we give a 400 micrograms of buccally or pervaginally. We generally repeat doses of misoprostol at 3 hours. But for this patient, we instead of 400, if we give 200 micrograms of misoprostol at increased dosage intervals, let's say 6 hours, if she does not abort, that will be a more rational option. And as Madam was rightly saying, that it's always better if we admit this patient to prevent any risk of excessive bleeding or any other complications. Before giving misoprostol, we take a consent, we take a detailed informed consent with counseling the woman about what can be the risks and complications after we administer her misoprostol, and also take a consent for laparotomy. Suppose after giving 2 doses of misoprostol, she does not abort, but in case she, on the other hand, she starts bleeding, so we, or she shows signs of uterine rupture, then we need to go for an emergency laparotomy. So all these needs to be explained.
What you are telling is that the dose should be tailored.
Yes.
Lower doses.
Lower doses at increased
the dose
frequency.
should be decreased with increased interval. So what do you mean by that increased interval?
Ma'am, increased interval, as I said, that according to WHO protocols, we misoprostol 400 after administering mifepristone, we give misoprostol 400 micrograms, either buccally or vaginally or sublingually. We give it every 3 hours if the woman shows no response. But in case of, instead of 400, if we give 200 micrograms, instead of 3 hours, we increase the interval to 6 hours. Then we are administering medical method. At the same time, we are also being wary of the complications.
So, Madam Dr. Alka Pandey, please give your comments, Madam.
Hello.
Madam, what should you do?
Nahin.
This is 2 cesarean with a scarred uterus, and medical abortion is being done. Yes.
Yes, but we have to be very alert, and we have to look. What I think the hourly intervals, they have given 3 hours, but what we are doing is every 6 hours we are practicing, and the dose of misoprostol has to be reduced. What do you do? Every 3 hours.
Can I interrupt, Rekha?
Yes, Madam.
You were talking of first trimester abortion or second trimester abortion?
Second trimester abortion.
Second trimester, ma'am.
13 weeks, no? 13 weeks.
Yes,
Because
as Alka said very rightly, that the interval should be increased.
First trimester is not much problem, because you will do cervical priming, and then you will that becomes quite easy. But in cases of second trimester abortion, sometimes the pain does not start, and sometimes there's much bleeding. So we have to be very careful, and we have to use smaller doses at increased intervals.
Basically, you have to titrate and see the effect and then proceed.
Yeah, right.
That is, every patient is different and in a different way. But one more thing that is mentioned is that, of course, you should always prime the cervix so that if you have to go on for the
dilatation of the cervix.
So priming of the cervix is very important. It should have been done so that if required suction, fast suction, and the patient can be transferred to the OT in a scarred uterus.
Now we are not getting laminaria tents properly. Previously, we used to get quite thick laminaria tents. We used to use them in a 12-week size uterus or 14-week size uterus. That was very helpful, but now we are not getting laminaria tents.
Police catheter can be used.
Madam, misoprostol 200 or 400 microgram can that can also dilate or priming of the cervix.
Madam, आप कुछ बोलिएगा?
Actually, what I want to say that once you give mifepristone to these patients, and you wait for at least 12 hours, then automatically the ripening of the cervix is done. And then you can apply a smaller dose of misoprostol, like 200 milligram only. And in majority of my cases, which mostly second trimester I do for congenital malformation and intrauterine fetal death. Even previous 2 cesarean section patients do not give much trouble. After having ripened the cervix, even 200 microgram of misoprostol works well. And in most of the cases, even we do not need to give second dose after 6 hours. Or at the most, you have to give only 2 doses. And most of the patients do not require third dose at all. And 50% of the patients expel after 1 dose only.
Yes, but one thing what I have come across is bleeding is too much with these prostaglandins. So what I have started now, give mifepristone and misoprostol 1 dose, follow it with pitocin drip.
Good evening, Anita ma'am. Just I want to know whether you are using this misoprostol only after 6 hours or on day 3rd.
No, after 12 hours.
After 12 hours,
Usually
not on day 3rd, not.
Evening, I give mifegest, and in the morning I start giving misoprostol. So whatever happens, it happens in the day. And the patient
12 hours.
and there is minimal amount of bleeding if you give these 2 combinations. So I might have been lucky up till now, but I didn't find any.
Yes, madam. I had described one case in which there was intestinal adhesions, and the scar rupture was there, and the intestine was inside the uterus, and then we had to repose and go for laparotomy. So that can also happen in the private setup. I think such cases are not coming. That is why you have really been lucky. But yes, these things, whatever you have really studied for so many cases, is worth looking into and worth following. We should try that, what you have told us. So, though no clear recommendations about the dose and protocols in the scarred uterus, but evidence says that misoprostol is not contraindicated in termination of pregnancy in a scarred uterus. Given less amount of dose, 200 to 400 mcg instead of 400 to 800 on day 1, and increased interval of 6 hours instead of 3 hours. What about the place of surgical methods? Dr. Kavita.
Yes, madam. So there are many surgical methods. If the woman has missed just 2 or 3 weeks, then we can go for menstrual regulation that uses a 50 ml syringe, and that will evacuate the uterus. So this is called menstrual regulation. Or we can go for suction evacuation. That is a process where products of conception are taken out with the use of suction cannula. That is connected to suction apparatus, and mostly the number of weeks of pregnancy coincides with the number of the size of the cannula. Like 8 weeks pregnancy, we can use 8 number cannula. That is Carmen cannula. And here electricity is required and mostly done under paracervical or short acting anesthesia. But there are another option like manual vacuum aspiration, which uses 50 to 60 ml syringe. Here electricity is not required and it is very useful in rural settings. And here we can do MTP up to 7 weeks of pregnancy easily. And here products will be sucked out and we can take in the syringe, and then we will see whether it has been complete or not by seeing the grating sensation or stoppage of bleeding, closure of the cervix. So this is manual vacuum aspiration. And another method is dilatation evacuation. That can be 2-step procedure. In one step, that is a dilatation simultaneously with the evacuation. That is done in earlier weeks of pregnancy. And if the uterus is not scarred, here we can do 1-step procedure. And that cervix is dilated slowly with Hegel dilator, and then we can do evacuation. Or we can do 2-stage procedure where we can use misoprostol or other hygroscopic dilators so that cervix gets dilated, especially in larger weeks of pregnancy.
How many hours before the procedure would you like to?
Madam, minimum 3 hours. Misoprostol should be given at least 3 hours before, or it can be left for 6 hours to 8 hours, seeing whether the patient is bleeding much more or not. Because if the patient is bleeding profusely, then we can do evacuation immediately. Otherwise, we can leave 6 to 8 hours. By the time most of the products are taken out spontaneously, and then we can go for check curettage. So, misoprostol is very good drug, and we can use it vaginally, sublingually, buccally, and it can dilate the cervix. And hysterectomy, it has been already explained. It is also called uterotomy. It's mostly not done, but if the placenta is low lying and if there are chances of bleeding, and even during dilatation evacuation, if suppose there is chances of perforation, then we have to go for hysterectomy, and then we have to take out the products of conception. So these are the steps.
Hello, madam.
I think we have another panel also, and it is almost 1.5 hours.
So we have to stop this.
Yeah.
Before stopping, Lekha ma'am, before stopping, will you, Dr. Datta is there?
Yes, Dr. Datta.
Dr. Datta. And he will say something about the high risk, like the sickle cell disease, and in case of rheumatic heart disease, he will say something about all.
No, madam.
Indications.
No, thank you very much. What I'm telling you in my practical things I've seen in the rural area, regards the medical abortion is very difficult because the medicine is supplied by the pharmacist. Now one problems. So I have the meeting of the government of India. Can you hear?
Yes.
I have the meeting of the government of India in the Guwahati. What I mentioned categorically, when you are giving the timing of giving the dose, some area they are giving the 4 p.m., some area they are giving the 10 p.m. No, it should be always done at the fixed time in the morning, either 9 or 10 a.m. in the first dose, and third dose the same time, same day. Otherwise, it's very difficult because if you give the dose in the 4 p.m., then the bleeding may occur in the night. So it's very difficult to control the bleeding. So therefore, the government of India agreed this point that the timing and the dose will be fixed. That is in the morning 9 a.m. or 10 a.m. and the first and the third day the same thing. Second thing, madam, about I've heard everything is okay. About the scarred, this one, here this is a problem. I cannot agree with what the World Health Organization respected they are in the placenta is in the lower segment, that is a bleeding from the lower segment. It is a very difficult to control, especially I'm telling, working in the tertiary layer hospital. So here it is something difficult. So in my patient, what I'm doing, when you find that the maximum amount of blood supply is there, when you find that the inferior parietal like this, I always open. I never give any drug, misoprostol, because in the rural setup is very difficult, or in the subdivision also very difficult. So better to open and do it very cleverly, because otherwise it is very difficult. Second things, the descending cervical artery. If the excessive bleeding is there, descending cervical have to be tied. Not ascending. Descending cervical artery, if possible, you can tie. before doing the operation, because the bleeding is coming from the lower segment. That is a descending cervical artery. That should be, we must care. This is the things. As regard the madam said that the other method, I always say that a sickle cell disease is very difficult for us. Our setup is very difficult. So you should be very carefully taken the sickle cell disease. I know it very well. So thank you very much, madam, because I am from Kallani to Durgapur, coming to my son house. Now I reached the Durgapur. So thank you very much to take me the expert of this panel. So again, I repeated this. Abortion is still unsafe in the rural area, mainly in the industrial area, rural area, and Adivashi area. So with this, thank you very much wholeheartedly, madam. You are doing the excellent moderator, and all the panelists are excellent. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you so much.
And
Alka ma'am.
Rekha ma'am, I think we should move on to the next panel, ma'am. We have the next panel as well.
Okay, so I should stop sharing the slides now.
Please stop sharing the slide right now.
Yes,
Alka ma'am, please give your concluding remarks so that we can finish this panel also.
Okay, thank you very much for including us.
Thank you, madam.
Thank
you,
you,
Alka madam, Rekha madam, for making us a part of webinar.
Alka madam.
Thank you very much.
Thank you very much,
All
Alka
the
madam.
panelists, to Rekha, to Satabdi, to Monica.
Very nice panel.
All of you have done so wonderful job. All the panelists were brilliant. Rekha is marvelous.
Thank you, madam.
Thank you, ma'am.
Thank you, ma'am.
Thank you. Thank you, ma'am.
Thank you, madam.
Thank you, madam.
Thank you, ma'am.
Thank you, ma'am.
Thank you, ma'am.
So, Monica.
Yes, ma'am. Yes, ma'am.
So we have got madam's blessings, and even Anita added some inputs during this session, and we can, with the permission of Madam Alka Pandey, move on to the next session.
Next panel. Yes, ma'am. Thank you all very much. It was a lovely session. Abhishek, please start sharing screen for the next panel, please.
Yeah, can we have the slide of Dr. Hara Patnaik, sir, please? Because sir has been waiting for the... sir is currently the Vice President of Fogsi in the year 2019. He was also the Secretary General of Vaginal Surgeons of India. He is President of Indian Menopause Society in the year 1516. He was also the President Association of Obituary Society of Odisha. We welcome sir to the panel and the program overall. So sir has been waiting since 5 o'clock, and we will not be able to hold the talk as Basaf sir is traveling. So I would like request sir to please give his remarks before we start the next panel. Patnaik sir? Sir, please join with your audio. Your audio is muted. अभिषेक सर को फोन कर सकते हैं?
यस मैम, एक्चुअली सर ने उनका ऑडियो ज्वाइन ही नहीं किया।
हाँ, वही इसीलिए उनको फोन करिए। तब तक आप शताब्दी, we can carry on with the next panel right now.
Yes,
because everybody...
Okay.
Yes, yes.
Sure, ma'am.
Please share the slides, Abhishek. We'll move on to our next panel. That was indeed a detailed discussion on MTP in high-risk pregnancy. Our next panel for the evening is on cafeteria approach for contraception. We have two brilliant moderators over here, Dr. Ashish Mukherjee sir and Dr. Indraneel Datta. Can we have the slide? And our expert panelist is Dr. Anita Singh ma'am. Can we have Dr. Ashish sir slide, please? Dr. Ashish Mukhopadhyay is the principal and professor and unit chief in gynecology and obstetrics at the CSS College of Obstetrics, Gynae and Child Health, Kolkata. He was the vice president of Fogsi 2016-17 and the governing council member ICOG 2021-22. We welcome you, sir. Our next moderator is Dr. Indraneel Datta. Professor Indraneel Datta is a professor of medical college in the IQCT and NH Durgapur, West Bengal. He is the immediate past president of Kalyani Obs Gynae Society
the executive member of YTP committee, as well as the East Zone coordinator for Public Awareness Committee. He is the IMA Standing Committee member for Antimicrobial Resistance between 2018 and 2022. Welcome, Dr. Indranil. Our expert panelist for the session is Dr. Anita Singh, ma'am. And we have the slide, please. Abhishek, Dr. Anita Singh, ma'am, slide, please.
Loading better.
Okay. Yes, we have Dr. Anita Singh, ma'am. Thank you, ma'am, for your deliberations on the earlier panel as well. Ma'am is the chief consultant at JP Hospital, Patna. She is ex-professor of Patna Medical College. She was the vice president of Fogsi in 2022. She is the president of AOGSBJ and chairperson of the IAG chapter of Bihar. Welcome, Anita, ma'am. We have an elaborate panel of 9 panelists today. Yes, we have first on the panel is Dr. Niladri Sen. Dr. Niladri Sen is the head of department of OBGY department at Durgapur Subdivisional Hospital. He has a special interest in laparoscopic surgery, NDVH and infertility. He is also FMF India trained for fetal medicine. He is a practicing gynecologist and obstetrician, laparoscopic surgeon, and a national and state trainer of the Department of Health and Family Welfare. Welcome, Dr. Niladri. Next, we have Dr. Sangeeta Thakur, ma'am. Sangeeta, ma'am, is a practicing as a consultant gynecologist at Isar Nursing Home. She has performed more than 10,000 plus surgeries, including a female with her 5th cesarean section, and she's the secretary at the Saharsa Obstetrics and Gynecological Society. Welcome, ma'am. Our next panelist is Dr. Moshumi De Banerjee. She is a consultant gynecologist at ESI Hospital, Shialda. She is the president-elect of the Bengal Obs and Gynae Society. She has been the organizing secretary of BoxCon 43, FWCon 2017 and BIMACon 2019. She has special interest in gynecological laparoscopy. Welcome, ma'am. Next, we have Dr. Helen Kamai. Ma'am is the associate professor at Jawaharlal Nehru Institute of Medical Sciences, Imphal. She is in charge of gynecological oncology at the Department of Obs Gynae, member of IACCP, AGOI, Fogsi and ISAR. Welcome, ma'am. Next, we have Dr. Nivedita Datta. She is a consultant GNO and the president of Bokaro Obs and Gynecological Society. She is the East Zone coordinator for the Safe Motherhood Committee as well as the Manyata coordinator for Jharkhand. Welcome, Dr. Nivedita. Next slide, please, Abhishek.
Ma'am, might be it will get loading later. It is already on screen.
Okay. I guess we have Dr. Mriganko Moli Shah. Yes, we have Dr. Suman. Ma'am is a senior consultant.
Very good afternoon.
Dr. Suman Sinha, ma'am. Yes, ma'am is a senior consultant of OBGY at AHIVF and Infertility Center at Ranchi. She's a director of Advanced Care and Maternity Center.
Good afternoon.
Have you stopped sharing the slide?
Abhishek, please don't stop sharing the slides. For the next slide, please.
सुमन सिन्हा मैडम अभी बाकी है मैडम को इंट्रोड्यूस करो निवेदिता मैडम का हो गया है
Yes, Suman Sinha ma'am का ही चल रहा था. ठीक है. Ma'am is the organizing chairperson of Fogsi Zonal Conference with Yuva 2022 and convener of the Public Awareness Committee. She has been between 2011 and 2013. Welcome, ma'am. Ma'am has various awards to her credit. Welcome to the panel, ma'am. Next, we have Dr. Mriganko Molishaha. He is the assistant professor in obstetrics and gynecology at the College of Medicine and JNM Kalyani at Kalyani, West Bengal. He is also the president of the Kalyani Obs-Gynae Society, associate member of RCOG UK, and he has many international and national publications to his credit. Welcome, Dr. Mriganka. Next, we have Dr. Tamami Chaudhary. She has done her DGO from Calcutta Medical College, and she is a consultant at Siliguri over here. She is attached to Mitra Nursing Home and Balaji Healthcare at Siliguri. Next, we have Dr. Isha Sharma. Unfortunately, she would not be able to join us for.
Okay.
Okay, Shatabdi, you are muted.
The names of the moderator and panelists itself is a panel discussion.
Yes. So you please, we now hand over to Dr. Indranil and Ashish sir. Please carry on the panel. Please carry on. Yeah. Thank you for the patient wait.
Ashish sir. Good evening, everyone. It's a pleasure to see so many panelists. Probably we can apply in the Guinness Book of World Records. The number of panelists we can include in the panel is increasing day by day. And after the corona, we can see the increase in number of the panelists in each panel. That happens everywhere, including AICOs. So hearty greetings from East Zone and Fogsi. And I convey my respectful regards and thanks to the organizers. I know the PAC is a very, very happening committee. And Dr. Rishikesh Pai, Dr. Priyankur, and everybody that is in Madhuri Patel and Alka Pandeji, the softest vice president I have seen in my life. Dr. Kalyan Barmade is the past chairperson of PAC. And the coordinators, Monica Umdarband, or I don't know if I have spelled it right or not. So I have had a convenient, another way of saving her name. So I have done that. And we are extremely grateful to have such great panelists, and along with Dr. Indranil Datta, sorry, Professor Indranil Datta. Yes. Upon a time, my student, but now he is my teacher. And, and it's very nice to see so many familiar faces, like Nivedita, like Shuman, my favorite Suman, then Roma, then Mriganko, then Moshumi, the next president of the Bengal Vision Society. My another favorite student, Dr. Niladri Sen and Rekha Jha, Doctor.
Me also. Yes, sir.
Yeah, Niladri, I took your name. Anyway, the previous panel was also very good, very interesting and very happening panel. So now the time has come that to ask those familiar questions. Am I visible? Am I audible? And is my slides visible? So I will share my slides now, if you kindly permit. Am I the co-host now? Can I share?
Yes, sir, you can share now.
Okay, thank you. Just give me 2 minutes time to share the screen. Can you see the slide? All of you?
Yes, sir.
Yes,
Yes,
sir.
sir. Just make it full screen. Yes, sir. Perfect.
Full screen now?
Yes, sir.
Visible, audible, and your slides are visible.
Oh, fantastic. That's what we wanted. Anyhow, so the topic is cafeteria approach for contraception. It's a very interesting topic and perhaps the most significant topic in today's era of multiple needs in contraception, unmet need of contraception. Now, in the preliminary part, we will just, we all know what is contraception, that means preventing pregnancy. Family planning means keeping the number of family members to a specified number by the method of spacing and timing of their births. We have to remember that terminal programs like sterilization, vasectomy, these are never a good method of family planning. So that it took us many years to understand this. India as a country has always insisted on terminal methods. And the result is that we could not achieve family planning properly. So family planning is a different issue, and spacing and timing are the most important aspect of having the family planning. The unmet need, as I said, is an important issue also. Number of women that want to stop, pregnancies at a given point in time using any method of contraception, and also pregnant women whose pregnancies were unwanted or mistimed, and also the postpartum amenorrheic women. So all these women constitute a huge number of population that is the unmet need of contraception. And this is a very important issue whenever we want to discuss contraception. And we have discussed many methods, many ways of implementing this contraception and family planning. And ultimately, we have realized that cafeteria approach is the best approach, perhaps, for practicing contraception. So my first question will be, we all know the benefits of the family planning and contraception. It ultimately improves the nation's picture. So we won't go in that, but I would like to ask the panelists, what are the characteristics of ideal contraceptive? Is it available in the market? Anybody can say.
No, there is no ideal contraceptive, because when you say if there was such, then we would not have a cafeteria approach.
You won't have that panel also then.
Yeah, absolutely. So because an ideal contraceptive should be acceptable, accessible, affordable, without any side effects, and without it's even if you say like it should be palatable. So all these things are what make an ideal contraceptive.
Okay. So there is nothing called ideal. Even in human life, nothing is called ideal. So therefore, we have to have some compromises. And there are many methods of contraception available. And that is why we have to pick and choose. And we know all these methods like hormonal methods, emergency contraceptions, IUDs, permanent methods, barrier methods, spermicides, etc., etc. If you draw a tree of all the contraceptive methods, you will see that as you come down from the tree downwards, you will see they become more traditional and they become less successful in contraception. And in the end, in the bottom, we'll have the calendar method or the barrier methods or the withdrawal, etc., etc., which are basically unreliable. But as you go up the tree, you will find all the modern methods of contraception and also which are extremely useful, the very, very minimum failure rate. So that's a very important issue. And this tree, always you have to remember in your mind while we go for counseling on contraception. So what is my question to the panelists? The first question is, what is a cafeteria approach? Just explain to us, what is a cafeteria approach?
Cafeteria, can I say something?
Yes, you can see many things.
Cafeteria approach is that you have to help the couple in choosing the contraceptive method which is best for them and which they can accept easily and it is affordable to them.
Okay, so the criteria that I think Nivedita mentioned in the very beginning, that whether it fulfills or not, and you need to, but one, I liked your word, that we need to help the couple. That means we are not going to select it, but they will select it. And therefore I say that choosing the right method of contraception is the prerogative of the couple.
May I add one thing?
Let me finish first, then you add. Okay. Then the job of the provider, what is our job then? If it is the prerogative of the couple, what is our job? We have to, all the detail, all the methods appropriate for the couple with an open mind, explaining the pros and cons and letting them choose the right one. So our job is to explain everything which is ideal for the appropriate for the couple with an open mind, and then explaining the pros and cons and letting them choose the right one. They will choose the right one. This gives a couple the confidence and comfort. Whenever they choose something, they do something, then they get the confidence. And that will improve the compliance. It's very, very important. Otherwise, the contraceptive compliance will not be good. Because the couple will go home and will think the doctor ne ye de diya humko. Hamara to choice dusra tha. So it's a method of choice for providing clear, accurate, and specific information for the methods which is best for the couple. So ideally, the cafeteria approach is quite difficult. It doesn't look very easy, doesn't look very difficult, but it is difficult to implement because the doctor's tendency or the counselor's tendency is invariably to intervene. Yes, now Mosumi, you wanted to say something.
Yes. Now we can do the gather approach, that is that we usually say, that is the greet, then ask.
Yeah, we'll come to that. Mosumi will come to that. That's a method of counseling. I just outlined the basic principles of the counsel, because to many people, I believe that the cafeteria approach is not clear. Many people think that I will show this the contraception and then pick up one and give it to them. That is not cafeteria approach. Cafeteria approach is you explain painstakingly all these methods, of course, which are appropriate for them. And then let them select that, yes, doctor, this is the right one for me, I think. So you cannot display like a product market. You cannot display everything and pick up one and give it to them and say, this is your contraception. That is not cafeteria approach. But the cafeteria approach is that the couple needs to select the method after hearing you out completely. And that is the ideal cafeteria approach. So with that, I will request Indranil to please go ahead.
Yes, sir. So like what sir said, the couple has to make an informed choice. With this, we'll go into our first case. Now, the current scenario with both the partners, they getting married early, but they want to, suppose the couple wants to delay the pregnancy for 3 months. Like we are talking about a newly married couple who are just married for 3 months. They want to delay pregnancy for 2 years, maybe for various reasons, maybe studies, maybe giving time to themselves. There are a lot of factors now because current generation, we know that it's good that due to equality, both the partners, the male and the females, are working towards the building up of the family. So this portion becomes very important for the newlywed couple, and we have to give importance to the fact that they want to delay the pregnancy. With this, Niladri, I know you have been working in a very busy atmosphere and very sort of atmosphere which deals with almost the whole city of Durgapur. Can you enlighten, like, how will you approach these sort of patients and what are the options you can give to this particular couple?
Thank you, sir. Thank you, Ashish, sir. Thank you, Indranil, for allowing me. At first, I need a proper counseling. As we know, day by day, our particularly the client's demand is increasing, and particularly they are quite mature. Even most of them come to our clinic after doing Google and all these things. So they know partly about it. This is very important. And I am not the first person that I am going to counseling just because they are already counseled partially. And thereafter they're coming to us, what is the exact one? So for this couple, we must discuss about the temporary protections. Obviously, they are newly couple and we should express themselves about their style of stay, whether they are staying regularly, whether they are staying irregularly. That is also very important before choosing anything particularly right for them. And thereafter, particularly like the cafeteria choice, already said, we choose for the temporary methods. And we know some of them, and obviously we explain about the pros and cons, about the all available products. And I will suggest them, you please say, and it will be helpful for them, and the right choice will be made.
I'll interrupt you here. I'll interrupt you. Sir, that is the ideal scenario. Now, what I want to know from you, do we actually, I'm not mentioning you, like in terms of general population of gynecology, do we actually give them that option, or we try to put some option into their head? Is it like that, or we really give them the cafeteria approach? Because this is what we want to discuss, like how to bring that patient into confidence of the particular gynecologist, and how the gynecologist also should be in confidence to actually give them so many options. So what is your say on this thing particularly?
Really, Dr. Indranil, that is the main factor. They used to come to us nowadays. They say whether we will go for OCP If it is the OCP, then whether which generation OCP is, obviously I will say that, okay, it's good for you. You just go for 4th generation OCPs, and we have the pill. The number of pill is very important just because we want to perfect cycle regulation. So this pill will be good for you. That is 24 days pill. You have to take it from the first day of your menstruation. And 24 days menstruation will be fixed on 20 for 2 years. This is very good for the patient if someone willing to take the pill regularly.
Okay. Sir, again, I'll interrupt. Nivedita ma'am, I want to bring you in this. This patient, particular patient, has anxiety about the use of pills because she is recently married. She looks good. She doesn't want to become fat. Like that general concept, like consensus among the young couple is, I'll become fat if I use the pill. How do we remove that fear of that pill? Nivedita ma'am, please.
Okay, we have to explain to her about the various types of pills available, because the major issue about weight gain and no weight gain depends upon the progestin component of the pill. So we have pills now, we have from the 1st generation to the 4th generation pills, and the newer contraceptive pills which are in the market do not cause any weight gain. So, and their side effects are much lower than the old ones, very easy to take, and the only thing is it has to be taken regularly. So we can counsel them about that, and if that, and obviously as Dr. Niladri said, they have anyway Google searched. So I'm sure they know about this, but and we can enforce and we can tell them that, okay, this is effective. You can try this and regularly monitor your weight. If you're so scared, you will see that there's no weight gain. However, here also I would like to point out that even with the old pills, it is not a marked weight gain. It is hardly 0.5 to 1 milligram weight gain, and you can easily counter that by diet and exercise.
1 milligram weight gain? What do you mean by that?
In a year. In a year.
You mean kg, you mean kilogram. Okay.
Oh, sorry, 0.5 to 1 kg in a year. Yeah.
Okay.
Also, the benefits regarding the OCPs we can tell.
Suman madam, have you actually used the newer combination pill of Dynogest along with the ethinyl estradiol? Like, what is your take on that? Because that is a newer product which has come into the market. How you are using that product in your?
I have used drosperinone one, not the Dynogest one.
Drosperinone we have used, but I'm asking about particularly the Dynogest combination.
No, the Dynogest combination, I don't know about the others, but I have not used it as an oral contraceptive pill. It has been used mainly for endometriosis.
Yeah, endometriosis I've used, but not as a contraceptive.
Yeah, most of the people are using it as a treatment of endometriosis. Yes.
Yeah, basically it is being used for endometriosis because of because the cost effect has come down because of making it like a contraceptive pill. Yeah.
So we take that message and move ahead. Yes, Indranil. Anything else? So these are the methods of how do they work, and this is the side effect that I think Shuman was talking about. And look at the side effects. Today's modern pills, we never write the side effect of weight gain anywhere. That's a significant statement because we need to show them that, like Nidya said, I completely agree with her, that the modern pills that do not cause an increase in the weight gain, and this needs to be conveyed to the patients who are other clients who are particularly concerned or rather sensitive about the weight gain.
As I tell them, modern pills for modern women.
Yeah. So that any particular instruction regarding taking the pill?
So you can take up the next case.
Yeah, as I've already mentioned that it will be the same time every day.
Same time every day. No, some people maintain that you should take the pill in the afternoon so that it has its maximum effect at night when the couple are uniting or meeting. Do you agree to that?
I usually give at night, bedtime, at dinner, so that they don't forget.
There are two theories.
Any time it is, which is any time which they can remember every time. But convenient to the couples.
What I was asking is that some people believe that the pill has got maximum contraceptive efficacy when given some time. So you take it in the afternoon.
Absolutely. They say the peak effect, if you take it in the evening at around about 4 p.m., and if they have coitus at night, then the pill efficacy is the highest. We really don't know about that because then they say the half-life lasts for about 12 to 24 hours.
But this is
So it
mostly
will continue.
true of the progesterone only pills, like just or something like that. But no other advantages of taking the pill. Only thing is that you should not forget the pill. That is the reason why we say the same time every day. Use condoms on antibiotics. Do you follow this principle, madam? Adri, Shumon?
Only those antibiotics which have hepatic bypass.
Hepatic conjugating enzyme. Okay.
Yeah.
Particularly when patient is taking ATD-like drugs.
Yeah.
Obviously useful.
Any hepatic inducing enzyme.
Yes, any hepatic.
And this is one beautiful concept that we used to say in cases of adolescent contraception. We missed this lecture today. Use condoms for 1 week if you miss a pill or take one late. But if you can take it, make it a contraceptive secret. That means the lady is taking the OC pill, the husband doesn't know that. So it's a contraceptive secret. That means the two-way protection, but the husband feels that it is the only method of contraception, that is the condom that he is using, and therefore he uses religiously. On the other hand, the wife is taking the pill for the better protection. So that is a very good concept, and it is ideal for people who have multiple sexual partners. Doesn't happen so often, but you need to mention that. But at the same time, you must remember that the pill offers no protection from STDs. Yes. So, with that, we move on to the second case. Cases of just, clinical scenarios, not cases actually. We just mention about this. A 44 years old lady, non-hypertensive diabetic, using copper T as a contraceptive. She has got copper T inserted 10 years ago and has come to your office for replacement of the device. Some another panel is going on, I believe.
Can we silence the other people? Yeah.
Yes,
Moderator.
list of the moderators.
Yes, sir. Yes, sir. In just a
Yes.
Okay. So she has got copper T insertion 10 years ago. It has finished working now, and she has come to your office for replacement of the device. She gives history of dysmenorrhea and heavy flow for 3 months. On evaluation, no organic cause was found. Do you think that this patient needs contraception at her age?
Yes.
Can't see the other panelists. I'd like to ask the other panelists, and at this time, who are the other panelists?
Dr. Helen.
Dr. Helen coming.
Dr. Helen is there.
My
Dr. Miganko,
Hello. Sir.
Oh.
Hello.
Yes, Helen.
Hello. Yes, sir. Good evening.
Yes, I am here.
Well,
Listening.
My network is very unstable.
Helen coming first because she is the future chief minister, and then Mriganko.
Sir. Anyway, thank you for the vote of confidence.
Actually, I wanted to say ladies first, लेकिन मुंह से निकल गए future chief minister. क्या करें बोलो?
पता नहीं आप ऐसे ही बोलते हैं हमेशा.
Okay, Helen. So do you think that this patient, 44 years old lady, she has lost her necessity for contraception? She has taken one copper T 10 years ago, and do you think enough is enough? Now you go back home, you don't need any contraception. Do you say like that? Or you said, no, you need another copper T. Come, I will help you with another copper T. What do you say?
Sir,
Or you give another contraception. Yes.
Yeah, another form of contraception maybe, because 44 years perimenopausal doesn't guarantee that she won't get pregnant, because we know that although the fertility rate falls, this patient is still susceptible to pregnancy. So definitely we should offer her some sort of contraception and like offer her what are the options that she has available, because she has so many complications along with age. She's hypertensive, she's an established diabetic patient. So yeah, definitely she needs contraception. Maybe I won't give her copper T, but yeah, definitely alternative form of contraception she should take, because she's not immune to pregnancy still until menopause sets in.
What do you suggest? I'll ask this question to Moushumi. Moushumi, what do you suggest for her?
Unmute yourself, Dr. Moushumi.
Okay. Yes, Ashisa. Actually, she is a premenopausal age group. So I will give her the choice of LNG IUS after an endometrial biopsy. We are going to do an endometrial biopsy and then give the LNG IUS. And if that endometrial biopsy comes something wrong, then we can counsel her for later surgical procedure. And if it is okay in a benign, then she can continue. That will give her contraception, as well as that will treat her for dysmenorrhea and heavy menstrual flow.
Okay, she's having heavy menstrual flow at the age of 44 years. So, Mushmi, I tend to agree with you that she needs an endometrial sampling. Having said that, after endometrial sampling and with a history of heavy flow and dysmenorrhea, would you go for LNG IUS or you would prefer another method of contraception?
I will go for LNG IUS, counseling her that if the endometrial sampling turns to be benign, she can continue with that procedure. But if it is something wrong, or if it is,
then obviously we won't.
Then we can go in for operation and remove it, right? So it doesn't take much trouble to remove LNG IUS.
I know. Let's see whether Meganko agrees with you or not. Meganko, what is your?
Can do it on the same sitting.
Just sir, one thing. Well, it is a 44-year-old lady, rightly told by Mousumidi, but at this age group, after sampling, if the report came as benign, definitely we can, as a cafeteria approach, can give the option of the LNG IUD as well as ormeloxifene. That's also good, works very well in this background. Dysmenorrhea with heavy flow, that takes some control. It can be optional, can be given.
Okay, so as cafeteria approach, you will help her to choose something. And what will be your points in favor of ormeloxifene?
See, ormeloxifene is basically the estrogen selective SARM. So it just antagonizes that estrogenic activity and it controls the menstrual bleeding and dysmenorrhea. That's the benefits of the pros of the ormeloxifene.
But will it cure the heavy menstrual flow? Are you sure about this?
Sometimes ormeloxifene as a selective estrogen, as it is a estrogen selective SARM, it controls the heavy flow. It has been published in the papers also.
Nivedita, do you rely on the barrier methods of contraception or injectables? There are other methods.
Yeah. Progesterone injection
in this woman who has a history of diabetes, hypertension, I would not really rely on the injectable contraceptives, but barrier method can be used, can be suggested. However, even I would agree with Dr. Moshmi, that would have been my first choice. I mean, if on a cafeteria method, I would have given more stress to the LNG intrauterine system.
Yeah, I like that answer. That is a very good answer. That because the common human or the doctor's feeling is that she's already out of one copper tea. I should not use another intrauterine system, something like that. We have some mental block, but ideally, I think in this particular case, ideally it's a case for LNG IUS. I agree with you, Moshumi and Nivedita. Okay, so we all know how does this injectable works, but the problems, yes. I think I'll ask about the problems from people who have used this maximum. Any one of you can come forward and say, what are the important problems of injectable contraception? In the government sector, we have used many patients, and I can share my personal experience, but I'd like to hear from the panelists. Yes, what are the side effects? Do you agree with this? Extremely irregular menstrual bleeding and
spotting, and they want to take it out because it causes spotting, irregular periods, and they don't want to carry it.
I believe
so
Suman is speaking.
Yeah.
I
have seen.
Yes. Who is speaking?
Dr. Niladri.
Yes. Yes. Bolo. Niladri bolo. What you have seen, Niladri? Okay.
And followed by that patient always wants for regain her menstruation. Now it is difficult for everyone to say when she will regain her menstruation. That is also major problem, I think.
Yeah, and sometimes the lady becomes so worried about amenorrhea. Yeah,
amenorrhea.
That whether this is working or not.
Whether it is prolonged.
Every time she will ring you up and say, doctor, my menstruation hasn't come this month also,
Yes.
should I go for the pregnancy test? So she believes that it's a faulty method of contraception. That is the major issue that I have faced in my practice. Yes, Sunil, can you take this case up?
Yes, yes. So coming back to the young couple again. So a young couple visits your OPD and gives a history of condom rupture at the time of sexual intercourse during the fertile period of the woman. Though I-pill was taken, but it was taken on the third day. Obviously, the couple is anxious and fears that the pill might not work. They have 2 kids and they do not want pregnancy. Moshumidi, what can be done now?
Yeah, copper T can be inserted, or you can give also mifepristone.
Absolutely.
Now, Moshumi, interesting. You are after copper T from the very beginning of the panel. I can see that. Why can't you go for the copper T approach? Why can't you say that? Why in this case in the copper T? I'd like to know.
No, I mean, if we give copper T, then it works. It works better. I mean, the less failure rate is there.
It's an interceptive
Less
also.
failure rate is there.
They are mainly concerned about interception.
I want a very confident answer that copper T under the circumstances is perhaps the best interceptor and the contraception.
Yeah.
That kind of answer.
May I?
Okay.
Yeah.
Yes,
May I,
Shwan.
sir?
Helen, madam, yeah. Yes.
Dr.
No
Helen
LNG,
Dr.
I think.
Helen wanted to say something.
Dr. Helen wants to say something. Yeah.
Yeah, she took the I-pill, sir. She took the I-pill, but on the third day. And yeah, as the duration increases compared with the time of the exposure, therefore the efficacy also reduces. And I think I agree with the copper T thing, because for another advantage to that aspect is it is a long-acting contraceptive also. And these are couple who have already 2 kids and they do not want pregnancy anymore. So once we insert the copper T, that may have a long-term impact also regarding their wanting to avoid further pregnancy. So I think copper T, that's why is an ideal method, I mean, to get off their apprehensions regarding the pregnancy.
Megango, can we use the LNG? Megango?
Yeah, basically LNG may be an option, but as a cafeteria approach, the 72 hours has already eclipsed. So there is a chance of failure of the IP. So best method is always, I agree with the Mousumidi, that copper T. It can be 10 days. 10 days, within 10 days.
And mifepristone. And
correctly mentioned.
Mifepristone too.
I'm very impressed with the answer of Helen Kami. No wonder she was given the post of Chief Minister. Now I give her the Health Ministry also. She has to take care of the Health Ministry also. Helen, thank you very much.
Thank you, sir.
Now, what happens after 72 hours of unprotected intercourse? Copper T insertion is the most effective means of contraception. IUD is preferred in women who desire IUD as a long-term method of contraception, and I think this was adequately highlighted by our learned panelists. And the copper T that we use is T copper 380A or a multi-dose. I think people will be heavily preferring T copper 380A. Important point. Okay. So I think we'll skip these slides on the IUCD. We know a lot about IUCD and how does it work, the chemical and the cellular changes. And the most important thing that has been elucidated today by science is that it actually is spermolytic. So hinders spermatozoa function, motility, and even kills the spermatozoa. That's the most important mechanism of action now. Previously, we used to depend on all these changes, cellular changes and chemical changes, etc., etc. This is about LNG IUS, just 2 or 3 slides, not recommended in this particular case, but it releases 20 microgram per day of levonorgestrel. And we have a lot of non-contraceptive benefit. I think we have discussed that in the previous case, reduction of blood loss and etc., etc. We have prevented many hysterectomies by using LNG IUS. And there are some newer LNG IUS which are either coming up or they're going to come up very soon. One is Fenulis and another is Fibroplant. This is a shorter sidearm device, well suited for nulliparous women, because the nulliparous women always had the difficulty of a pinpoint os and this LNG IVs difficulty, insertion difficulty. Fibroplant is frameless, 2 version releasing 14 micrograms per day and 20 micrograms per day. There are 2 versions, 5 years duration of action and suitable for uterus of any size and shape. So these are the new products that are coming up in the market, and we need to take note or watch of the market. We all know the advantages, but the most important thing is immediately reversible and is ideal for spacing. But the disadvantages of menstrual irregularities, you need a trained person. But I must also mention that the insertion techniques these companies are making it simpler and simpler day by day. It's very simple now, and I believe that previously the Mirena insertion was a bit technical, but now it is extremely easy. So there is no problem about that. But the other things about risk of expulsion, other things are there. Complications, all of us know. And we must not forget the vasovagal attack and the spasmodic pain, uterine perforation. These things should be there. So one should not be very casual about this, but yes, it's a very good option. Yes, in selected cases. Indranil, can you go ahead with this fourth?
Yes, yes. So coming about our next case, a young female, Paragon living one, working in a multinational company, is seeking an effective spacing method. And obviously she has heard about the newer vaginal contraceptive rings from one of her friends. Now, can we ask one of the panelists, I think Nivedita madam, can you brief the audience like about the vaginal ring, and have you used it in your practice, and how to proceed and how to guide the patient?
2 questions. One is, let me take the second one first. That is whether I have used a vaginal ring on any of my patients. And let me tell you that the place where I'm working, vaginal ring is not available. In Jharkhand, there are no vaginal rings. However, the second part, the first question which you asked about what is a vaginal ring is basically, it's like a pessary, it's like a ring, which is again encoded with the hormones. So you can have estrogen progesterone hormones, or you can have plain progesterone hormones on the vaginal ring. It is inserted. Normally, the common one is a Nuva ring, which has got estrogen and progesterone. And it works just like an oral contraceptive, except that instead of swallowing it, you're putting it inside the vagina. Very easy to insert. All she has to just know how, it doesn't have to have a very complicated technique of insertion. So it's very simple to insert and keep it on for 3 weeks, remove for 1 week. And in that 1 week, when she removes it, she has the periods. She can remove it. Usually there's no difficulty in intercourse, even with a vaginal ring in situ, just like we've even seen when we had prolapses and we would put pessaries. But if she's so uncomfortable or her husband is uncomfortable about it, then they can remove it during coitus, but not for more than 3 hours. It has to come back within 3 hours to have effective contraceptive effect. And if she can even clean it if she's particular about it, but then again, it has to go back into it before the 3 hours is up. So only break is for 3 hours if required. And this is it has also got a good cycle control. There may be a certain amount of breakthrough bleeding, but then that can also, if it well counseled, I think women accept the slight amount of breakthrough bleeding. They are willing to accept it. A lot of women accept that, but they have to be very well counseled about this. That is all.
Thank you, Nivedita, for an excellent lecture on the vaginal ring. You have done a wonderful job, and that was an oration on the vaginal ring. I have got some observations about the vaginal ring is that, somehow I have seen that the girls or ladies in our country, they don't like handling the vagina.
But sir, here I would like to say they're using progesterone vaginal tablets.
That is why Indranil had to add that multinational company. and the girls who are coming from the multinational company, they are not trained in handling the vagina, but they love to handle the vagina. That's what Indranil thinks. But the point is that the important advantage is that there is no way that you have to persuade them that, no, this has to go inside. Many people do not have the idea about the length and breadth of the vagina. Where does it go? What does it do? Etc. etc. These are big questions. Secondly, to me, the questions are 3 weeks on and 1 week off and frequent handling. They may not like also as well. And every time, suppose it fails for any reason or it causes some irritation in the vagina, then they will blame themselves that I have inserted it wrongly. That is why it may not work also. So there's always an amount of, doubts and questions in their minds about the efficacy, etc., etc. So I think that there are a lot of questions on this, and I really wonder whether some of us has got the, the expertise or using this in their patient population. The third point that I wanted to make is that the amount of the hormone that is here in vaginal ring or NuvaRing. In NuvaRing, a very low amount of estrogen is there. It's that the kind of plastic that is used, that is ethylene vinyl acetate copolymer, that is extremely inert. It doesn't cause any reaction with the vagina, but releases low dose of a progestin and an estrogen over 3 weeks' time. The efficacy is 95 to 99%. It does not require a fitting by a healthcare provider. Just put it inside because the hormone will work, not the position of the equipment which will work. It is available since 2009. It releases 15 microgram only ethylene estradiol plus etonogestrel, 120 microgram daily. I think this is the lowest amount of estrogen that is available. We have an oral preparation, of course we have, but then vaginal preparation, vaginal ring, they have claimed that it produces better cycle control, which is yet to be proved. I don't know about that, but they say that they produce better cycle control, but the oral preparation doesn't have this good cycle control. I wonder whether that is true or not. This is flexible, made of diethyl polysiloxane. Unlike vaginal diaphragm, it does not have to be a specific position in the vagina, and the failure rate is 0.3 to 0.6, which is quite good. Anything less than 1 is good. Anything around 0.5 is extremely good. So it has got a beautiful success rate. But then with all those disadvantages or all those questions in the mind of the patients. Anybody wants to add something on the contraceptive vaginal ring? You can. The option is, I think Nivedita said this, can be removed, the optional removal during intercourse. But I think this is also cumbersome for the patient. And then there's a hurry, you're putting it back. 3 घंटा होएगा, जल्दी करो, inside, put it inside. Then क्या होगा? What will happen then?
So this is another thing I would like to add about contraceptive vaginal rings is that in the presence of vaginal infections, the efficacy becomes less.
Again, the new thing. He has to wait.
Yeah. So that hurry curry that spoils everything, and messy. I can call it a hurry curry and messy contraceptive, but yes.
Sometimes what happens? Absolutely, sir rightly told all the points. Nothing to say. One thing is that I have an experience with that. I have prescribed one of my patients. So one thing, sometimes the patient complains about very irritation of the vagina, discharge. Sometimes some patients may complain, and often what occurs that that rightly told that the cumbersome procedure, removing, again putting it, sometimes patient may forget to put it and ultimately land up into the failure.
Yeah, Mriganko, thank you for the input. So I believe that this is the
one more question I would like to ask. One question here I would like to ask, and that is any interactions of a contraceptive vaginal ring with at that time prevalent vaginal infection or vaginitis, especially yeast infections.
It causes vaginitis.
If there is a prevalent, already the woman has some vaginal infections,
then how?
Yes, exactly. How effective would be the vaginal NuvaRing?
I'll bring Helen here because in her state, she has the maximum sunlight. So I would like to ask her opinion about the transdermal patch. Helen, do you have any experience about using transdermal patch in your patients?
No, sir.
You don't have? Okay.
No.
The sunlight is not so severe.
I just know the theory, don't know how the sunlight is affecting the patch. Not
okay,
the theory portion only.
I'll explain to you. Sunlight is affecting the patch because we live in a tropical country, isn't it? And the sweating and the other things that our skin
comes out. The patch comes out.
Patch comes out, and that is the disadvantage of the transdermal patch. And look at the areas of application of the patch. Okay. So I think that it is not very successful in our country. Anybody having any different experience with patch? Anybody
No,
having
sir,
an active
the
feeling?
patches are effective. The patches are effective. I mean, it's not that the patch doesn't stay. Yes, they have to be applied in a place where there is a relatively hairless area. It has to be applied, and you have to be very particular about telling them that no oil on that area, and so that the patch does not fall off. And anyway, the patch has to be discarded every week. So that's fine. After 1 week, they can remove. But the sticking quality of the patch is quite good.
But it is also very costly for our country.
Absolutely. I agree. I agree. It is very, very expensive. So it's not, but what I'm trying to say is that it does not, it sticks. It sticks, and it's.
Cause allergy to the skin also, no? It can cause allergy to the skin.
Irritation, allergy. So, Indranil, I think I will stop this patchy discussion.
Yeah.
And discuss the next case.
We'll go into the Chaya.
Yeah. Because we were very scared of the shadows, and now we have taken this case.
So, a 32-year-old school teacher, Paramount Living One, taking ormiloxibin, which is commonly known, very popular by the name Chaya, for contraception from last 1 year. Ever since she is on the pills, her period pattern is 3 to 4 days, interval of 40 to 42 days, regular average flow, and painless. But this time, her periods are overdue by 6 days. UPT done at home is negative. She always took the pill on time, and there is no history of missed pill. She is very anxious and wants to know if there any need to opt for an alternative contraceptive so as to avoid panic. Now, Niladrida, I think you can join us here.
Yeah. Niladri is there, or he has left in the right direction.
No, sir. No, sir.
I can start. Can I add
Yes,
something?
Mriganko.
Mriganko, তুমি আসবে, তুমি ormiloxibin chief আসবে।
HOD ormiloxibin.
Mriganko, you can.
No, not Niladrida said something, then followed by me.
Okay, Niladri, you first.
Okay, sir. Thank you. Particularly, Chaya, we know everyone that is a very good non-hormonal contraceptives, and nowadays we are using in our OPD also. And obviously, the dose duration, that is particularly 2 days per week, and for the 3 months thereafter, that means on day 1 and day 4, and followed by after 3 months, we can suggest her to continue it once in a week. That is a very good for every woman, particularly those who are working, that they can take this pill in a right way. But problem is that the same with a little bit irregular cycle, and obviously the cessation of menstruation, and people worried like this thing that whether she is conceived or not, that is a question. But particularly we can assure her to wait a little bit to regain her menstruation, and followed by continue this pill.
Mriganko, please.
Basically, what ormiloxibin, main advantage of the drug is very cheap drug, and it is also convenient dose that you don't need to take it regularly. It is twice weekly. You can start with that. After completion of the initiation phase of 3 months, then once weekly you can continue.
But is there a chance of forgetting more, Mriganko?
Yeah.
If you have to have something which is twice weekly, isn't the chance of forgetting more?
Sir,
I'm just asking.
Everything can be forget. Na? Twice weekly can be forget. Once daily can be forget.
No, Mriganko, you remember the government of India's family planning policies and the what should I say, that immunization policy, that every 2nd and 4th Tuesday and Friday of every month the vaccines are given, and they always forget which Tuesday and which Friday. So I think that's why I ask you, how do you convince your patient about
that is a practical point.
Okay, ठीक है, चलो एक अच्छा पेशेंट मिल गया आपको, 30 milligram twice weekly for 3 months, and then 30 milligram once a week. Yeah. Okay, so you recommend this, right? But why don't you recommend it to all women? Is there something, a problem with the failure rate, or some problem with the side effects? What is it?
got
Yeah,
an
definitely.
estrogenic effect on the bones. So if you use it for quite a long time,
Hello, am I audible?
then there
Yeah,
may
yeah,
be
audible.
some.
You are audible.
Yeah, so I was just continuing that. Forget, that is the thing that patients sometimes forget because that twice weekly dose. That is the major that is the cons, I think, major disadvantage of these pills. But if the patient can maintain the calendar, that can be minimized. Whatever maybe in the answering the question, the delay sometimes even 10 to 15 days. That is normal.
I
The
think
main
this is
thing is that if you forget the pill for more than 7 days, then you have maybe in a trouble. So in this question particular, patient has just overdue for 6 days or 7 days like that, but she has not missed any pill. So I think if there is a normal scenario, side effect of the pill, that we have to counsel. That's just.
I think the most important problem that we face in our hospital practice, because Chaya is, in spite of having a good this thing, I mean the formulation and a very good packaging. Chaya has got a very good packaging now. If you look at the Chaya package now, Government of India has improved the packaging very much. But in spite of that, the usage hasn't increased to a significant extent. Okay, so the reason being, there are two disadvantages. One is the delayed period like this lady had.
Yes.
And whenever you have a delayed period, you have some mental questions in your mind, and the husband, the mother-in-law, everybody is troubled and worried. And the second thing is, I believe that the failure rate is a bit on the higher side. 2% failure rate today, we should not accept in any modern contraception. Do you agree, Mriganko?
Mriganko, will you give this to the multinational woman?
No, if the here I would like to say that we are anyway using Chaya for abnormal uterine bleeding also, and women are accepting it twice weekly. Unfortunately, the problem with contraception is that it is because it's not a disease. Women don't like to take it like in that fashion. If it was a disease, then woman would have taken it. The woman would have taken it. So with Chaya, one was that, of course, that forgetting, okay, it's Monday, Thursday, which is especially in the place where I'm working in Jharkhand, where they don't remember the year, how old their child is and the year of their own birth. They don't remember which is a Monday and which is a Thursday either. So they get confused about it, and that's how the failure rate is much higher with Chaya, and hence, in spite of such massive promotion by the Government of India, it didn't really take on. Chaya didn't really take on.
I think Suman hasn't spoken for quite some time now. She also belongs to Jharkhand. I think the Jharkhand experience can be shared by Suman as well. Suman, do you agree with?
No, I don't use it as a
Okay.
Your
voice has become softer. Why, I wonder?
Sir, I'm working in both sectors. No? So I'm working in a rural sector also, and I have this.
Your voice is stronger. I can understand this. Yes.
I'm a rural OPD.
Yes. So it's a good choice for some selective women. It cannot be the choice for all the women. That's what I wanted to know. And as you said, yes, about the treatment of abnormal uterine bleeding. I think that I think you brought out, and Nivedita brought out an excellent point, that whenever something is given in a scheduled manner as a treatment, everybody will follow. Suppose you ask the patient to have 2 tablets, one on Monday and one on Thursday, that to cure some condition they will definitely have. But if it has to prevent something like a prophylaxis or a vaccine or something like that, they will not have. So that's the problem. That is true of immunization also. That is why the problem happens. So I think we are coming towards the end of our panel. Indranil, can you pick up this case, please?
Yeah, the last case for the day, and 28-year-old woman. So Gravera 2, abortion 1, presents into the OPD with 6 weeks, 2 days of gestation for MTP. She gave an history that the index pregnancy resulted due to contraceptive failure, that is condom rupture, followed by intake of emergency pill within the prescribed period, which resulted in the failure 2. And her previous pregnancy also resulted due to contraceptive failure. She is on antidepressants for last 5 months, not planning pregnancy in near future. She is seeking for an effective contraceptive method but not willing for a IUS. So anybody can take this question. It is open to all the panelists.
I can have one question to Indranil. Indranil, do you love taking the history of condom rupture?
And young patients. And young patients.
And young patients.
All the patients have the same history.
Newly married couple, condom rupture is his favorite topic. Okay, so I think Mriganko, if you are silent,
I am listening to you, sir. How you are saying that I am
Speechless.
Okay, so what is your opinion? What is your take on this case? Bolo, what do you say?
Basically, sir, whether she is married or not, it is not written. So whatever, it does not have any relation with the contraception. So married for 2 years and she is some antidepressant for 5 months. So not pregnancy taking so long acting something, I think it will be beneficial to her.
LARC,
Long
so
acting,
you recommend long-acting reversible contraceptive.
yeah, there
Excellent
are
choice.
lots of things can be in a cafeteria starting from the contraceptive implants or the copper tea. These all things can be offered to her. Copper tea basically easily available. If she does not consent for that interferent device or like that, does not like, then we have to go for the implant like Norplant or the Implanon. These are the implants available. So we can offer to her as she is on the antidepressant.
Thank you, Mriganko. I think I will ask the last question to my favorite Helen Kamei, and her input about the contraceptive implant, or whether she has used this in her practice or not, and then we will go for the closing. Helen, what is your input? If you are still there.
Sir, yes. So yeah, contraceptive implant, I've never used it, but yeah, it's a good option for her. Although I think we can think of other contraceptive also. But one thing I'd like to say here is that, sir, she was using barrier methods of contraception and all. Na? It was not like she was taking OCPs or stuff like that. Because antidepressants, obviously, the obvious choice would be long-acting reversible contraceptive. And contraceptive implant, depending on availability, sir, I believe. So, like Dr. Mriganko was saying,
Okay, tell us one or two words about long-acting reversible contraceptive, LARC. What are the methods that you are recommending or you are using? Forget about implant. Implant is...
So out here, copper tea we use regularly. LNGIUS, most of the patients who come to us cannot afford anything. So we offer them the freely available ones, copper tea. We explain to them what are the problems that can be there involved with copper tea. So copper tea is like commonly used out here. I'm sure elsewhere in India also. Injectables, like we were saying earlier, because of irregularity in menses, acceptability is very poor, sir. So after one use, most of them come. So we usually go to copper tea as an alternative if they still want to delay or space pregnancy like that. So that's there, sir.
So with those inputs about LARC, and I think we have exceeded our time, so I'll stop over here. And I won't discuss about sterilization. Everyone knows about that. And I don't think that sterilization should be discussed as a method of spacing contraception and a method of family planning. I have said that at the beginning of the panel. That's very, very important to focus on the spacing method of contraception and a cafeteria approach. And I thank profusely all my panelists, with the note that all condom ruptures do not happen with the newly married couple. And a message for Mriganko is that whenever a condom ruptures, do not question about marriage, married or unmarried. These are the two messages I want to convey to my panelists. Thank you very much. All my panelists, you are excellent.
Thank you, sir.
Fantastic.
Thank you so much. Thank you.
Thank you, sir.
Keep the panel very lively.
Thank you.
Very nice.
Yeah, thank the moderators and the organizers.
Yeah, thank you so much.
Thank you.
Thank you, Indranil, and thank you all the
Thank you, sir.
panelists. Thank you so much.
That's nice questions.
Thank you.
So, Dr. Monica, are you there, or Dr. Sata?
Monica, over to you, Monica. This is for you, Monica. Thank you.
Monica's muted, she's not there. Anyway,
I will stop sharing.
yes, sir. On behalf of the PAC committee, Fogsi.
Ma'am.
Yes, she's there.
Yes, ma'am.
Oh, yes.
Thank you.
Monica is back.
Thank you so much, sir, for an excellent panel discussion. And the way you've taken the panel forward, we will definitely remember all the words that you've used for the cafeteria approach, and we will be able to guide us much better. I request Dr. Shatabdi Dey to please conclude.
Hello. Yeah, that was a lovely session. Thank you, Ashish sir, Indranil sir, Anita Singh ma'am, and all our expert panelists. I think Dr. Murlidhar Pai sir has joined. If sir could give some expert comments on that. Sir, are you there? Yes, sir is there.
Yeah, welcome, Murli. How do you do?
He has joined for a long time, and if he could only give some inputs on adolescent contraception, because Dr. Basab is not available to give his talk. So what we have missed out on adolescent contraception, we could hear from Dr. Pai. And
Dr. Pai, Dr. Patnaik, both of them are there. If anyone of you could just give some.
We'd love to hear from you, Dr. Patnaik and Dr. Murlidhar Pai. It's always interesting to hear these two giants.
Okay.
Yes, Dr.
Sorry, Doctor.
It's a pleasure seeing you always, Murlidhar. You look so fresh and you look so, invigorating that.
No, actually, I'm juggling between two webinars. I'm actually answering in other. I was introducing the speaker in our KCOG international webinar.
Okay.
Dr. Gabriel is talking on fistulas.
Okay.
I'm sorry, that's why I was muting myself in this particular platform, and I've also not heard your comments. So sorry, can you repeat what you asked me?
No.
Sir, actually, Basab sir is not there for his talk. He is not able to join for his talk on adolescent contraception. So if you could just throw some light on that, sir.
Yeah. Okay. Adolescent contraception. I didn't follow your panel discussion, Ashish. What I feel is adolescent contraception may be something which may be scandalous in India, but it is very, very much in practice abroad in Western countries. And actually, there is nothing to be actually scandalous about it. If adolescents are having consensual or mutual sex, then it is better we advise them the safer methods so that they will not get into the problem of pregnancy, because always it is better to prevent the calamities, especially that are connected with teenage pregnancy. So I personally feel, instead of having a moral judgment on these kind of issues, it is better we educate our adolescents. Of course, if we can convince them that better not to have sex because of various other reasons, social as well as medical and other reasons. But it is very difficult for an adolescent to convince that premarital sex or adolescent sex is not good. So the only other option is that educate them with the contraceptive methods. Now, as far as the contraception for adolescents is concerned, it is always better to go for what I say double method. You may wonder why double method. There are different issues. One is prevention of pregnancy. The second one is prevention of sexually transmitted diseases. Now, we all know that it's not just the STI, even the cancer cervix is directly now related to sexually transmitted human papilloma virus. And we all know the earlier the sexual activity and repeated sexual activity right from the younger age group and multiple partners. So adolescent sex usually will have all the three. One is early sexual activity, and in that particular age of excitement, multiple sexual activity, and sometimes the behavior is so that there is a high-risk behavior with multiple partners as well as. So all the three ingredients being there, which is a recipe for the human papilloma virus, and in a repeated infection with human papilloma virus, which will definitely lead to carcinoma cervix, it is not directly related to that. We must advise a condom. So that is the first contraceptive that we would have to advise to them. With this, which is in favor of preventing the sexually transmitted disease and a possible cancer later in life. The second aspect is the pregnancy prevention. Now, I just heard few minutes of talk in the panel discussion that when you use condoms, there's a failure rate with the condoms. So to take care of the failure rate with respect to pregnancy, it is always advisable to give a second contraceptive. That's why I meant double contraceptive for them. The second contraceptive, there are again cafeteria approach. There are lots of we have, but again with respect to adolescents, they are hesitant to take up the hormonal contraceptives for obvious reasons. They would have all sorts of misgivings and misconceptions about the hormonal pills. Now, the other option is LARC, that is long-acting intrauterine devices. That is best is LNG IUS. Again, the question comes here: is it okay to introduce LNG IUS in an adolescent girl? If they are having sexual activity, I don't see any reason why we cannot introduce LNG IUS. Now, one may debate whether LNG IUS is safe. Will it cause infertility for them later in life? Because copper T was definitely blamed for pelvic inflammatory disease and some sort of infertility in them. But that doesn't happen with LNG IUS. It is a progesterone containing device. It will act in multiple ways, mainly by creating a hostile environment in the uterus, as well as it will create some sort of a thick plug of mucus in the cervix. So it will some sort of prevention of the sexually transmitted disease in that way as well. That is especially the pelvic inflammatory disease. It may not come in the way of fertility. We have seen that in the adults who are married, when they remove the LNG IUS, they will get back into the fertility. So this way, it will act very nicely. They don't have to depend upon the pills, which they usually are scared
Can I
of.
request everyone to mute, except Dr. Pai, everyone to mute, please.
Yeah.
Monica, can you unmute yourself for a second?
Okay.
Monica, please mute yourself.
Yeah, no problem. So, so that way, what happens is they will be protected from the unwanted pregnancy. There is no fear of any hormonal problems due to taking oral contraceptive pills, and there is no issue of taking or forgetting the pills and all those things. And it is quite safe also. The LARC is quite safe. So that way, I personally feel adolescents, they should use double contraceptive. One is a long-acting one, which can work for 5 years, and for other protection, they must use condom as well. If the male partner refuses to use the condom, the female partner should use the female condom. I hope Ashish will agree with what I suggested so far. Thank you very
so
much for the opportunity.
Thank you so much, Murli. It's a very good platform to raise some issues like this. And you always raise some pertinent issues. Just I had one or two things to your very important statements. That one is that I agree fully with you, except that the concept of contraceptive secrets, we discussed it in our panel. What happens if the male partner comes to know that the female partner is using another method of contraception, then he won't use the condom that rigorously, which he should. And that is why I prefer to keep it as a contraceptive secret that the lady is using a regular contraception while I prescribe condom to the male partner. Otherwise, I fully agree with you. Secondly, the societal changes today demand that we must have, and I insist on the word must, that we must have a permissive role on the contraception and the sexual activities today. Because come what may, whatever we say, they will do this practice.
Yes.
And it is strongly dependent on the societal changes. It doesn't depend on your education or your preaching, etc. So I don't believe that this kind of preaching, what we used to do before, that don't do this is bad, etc. These won't help because they will do it as such. But I think the contraceptive secret, if we can practice, then I think is going to improve a lot of ways. And thank you for bringing up the issue of the cervical cancer, because that's a major killer in our country. And now we know that HPV infection, cervical cancer, the CIN, everything is a continuous process.
Yes.
Therefore, I think it takes a long role and a very important role in the prevention of cervical cancer. Thank you so much, Murli, for bringing this issue.
Sorry, I was just, in the other webinar, and
right.
I didn't know that I had to speak today. So suddenly it came. I just
I know.
came to my mind. I just spoke.
But thank you for bringing those issues, and these are the places where we bring these issues and discuss them. Thank you so much, Murli.
Yes, thank you.
So,
thank you, Ashish sir, and thanks a lot, Murlidhar Pai sir. I know you are not prepared to speak today, but you just took it up sportingly and really gave us some valuable points on adolescent contraception. And thank you, Ashish sir, also for adding to that. That was a good talk. I would now like Rekha ma'am to kindly conclude our session for today. I think we are done for the day. Rekha ma'am.
Thank you, Satabdi. So on behalf of the Public Awareness Committee, Fogsi, I would like to thank the office bearers, Dr. Rishikesh Pai, President Fogsi, Secretary General Madhuri Patel, Madam, and Vice President of this particular committee, Dr. Alka Pandey, Madam, and the committee chair, Dr. Priyankur Roy, to start this sort of a platform which will be going to all the zones with different topics on so that we all are enriched with the knowledge on all the aspects of obstetrics and gynecology. So the next will be for cancer cervix, as Satabdi has already said. And I would like to thank Dr. Anita Singh, Madam, Dr. D.K. Datta, Sir, who was one of the experts, Dr. Ashish Mukhopadhyay, Sir, you are sitting right now, and Dr. Murlidhar Pai, Sir, and Dr. Hara Patnaik, Sir, who has joined since the program started, though he could not give his inputs, and Dr. Unnamed people who have not joined also, but we should formally thank them for agreeing to come to this platform, like Dr. Basav, Dr. Gokul Das, and special thanks to Dr.
Bhaskar Pal.
Bhaskar. I was just coming to it. Special thanks to Dr. Bhaskar for even though he was traveling, he joined in for some time, and all the panelists, right from Dr. Roma, Dr. Kavita, Dr. Kiran, Dr. Sharmistha, Dr. Niladri, Dr. Mariam, Dr. Bidisha, whoever was present, and special thanks to senior members like Dr. Maushami De Banerjee and Dr. Suman Sinha, who is one of my best friend, and everybody who was involved in this webinar to make it a success. And please excuse me if I have missed out on some names. It might be so. But very, very much thanks to everybody who has joined, and a special thanks to Murlidhar sir, because he has really given good inputs. He went on to those places which our minds could not think also. So that was very good. I really appreciate that, sir. And thank you. Good night to everybody today. For coming over to this webinar, even though most of us are traveling. I have to also go to Varanasi tomorrow. And so thank you once more. Anybody else who wants to say bye? Good night.
Bye-bye. I am also going to Varanasi tomorrow. Thank you so much. It will be nice
to meet you there.
Thank you, sir.
Yeah, yeah.
Meet you there.
Thank you, ma'am. Thank you, sir. Thank you, everyone. We'll
Thank
see you
you,
all.
everybody.
again with the cervical cancer program next time. Yes, ma'am. Yes, Moshmi ma'am.
Yeah, thanks a lot. Thank you, everybody. I enjoyed very much to be a part of this program.
Thank you, ma'am. Thank you.
Good night.
Yes. Good night, ma'am. Good night. Bye.